faculties and delegates. Thank you for joining Shield Connect. I am Nishan Chawda, Regional Medical Advisor from Shield Healthcare. It's my privilege to welcome you for this wonderful series, Trending Ask series, which is organized by AGOG, that is Academia of Global Obstetrics and Gynecology, on Shield Connect platform. So in this task series, we will be covering the topic from A to Z topics. And today the episode G will cover the topic gestational disorders. So before we start with the series, let me show the short introductory video for AGOG. And with that, let me start the episode with small Vandana prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
And I'm happy to introduce the Master of Ceremony, Dr. Shehla Jamal and Dr. Priya Vora. So Dr. Shehla Jamal, ma'am, is Associate Professor and Unit Head at Medical Education Unit Coordinator in Rajshri Medical Research Institute, Bareilly. Ma'am is Menstrual Health Specialist, Medical activist, founder and President of the Society of Menstrual Disorder and Hygiene Management. Ma'am has more than 40 publications in national and international journals, chapters in published books, and also awarded with Foxy Mrs. Shelja and Pandit Award and Prashti Patra by Government of UP, Bareilly 2020. And also let me introduce Dr. Priya Vora. Ma'am is MOGS Managing Council Member for 9 years, Youth Council Mentor for 5 years, Secretary of Mumbai Menopause Society and AMWI Mumbai branch. Ma'am also received a RD Pandit Essay Prize in 2021-2022, MOGS Best Video Award, and peer reviewer of Jogi. So I hand over this session to Dr. Shehla Jamal, ma'am. Thank you.
Thank you so much, and a very warm and sweet welcome on behalf of AGOG, Incepted A to Z series in our task program. So we are opening up our G episode for elaborating evidence on gestational disorders. The program is convened by ace academician couple of the country. Yes, none other than Dr. Komal Chavan and Dr. Niranjan Chavan, sir. The series is seeing mind-blowing attendance and superb academics, which is benefiting thousands of learners across the nation. To introduce Dr. Komal Chavan, she is Medical Director, Chavan Maternity and Nursing Home, Senior Consultant, DNB Teacher, Unit Chief, VN Desai Hospital, Mumbai, ex-honorary Professor, Dr. R.N. Cooper Hospital and HBT Medical College, Chairperson of Foxy Medical Disorders in Pregnancy Committee, and she has done magnanimous work. So to cut short her CV with few words that I always wanted to say about Dr. Komal, अभी तो असली मंजिल पाना बाकी है, अभी तो असली मंजिल पाना बाकी है, अभी तो इरादों का इम्तिहान बाकी है, अभी तो तोली है मुट्ठी भर जमीन, अभी तोलना सारा आसमान बाकी है. So Dr. Komal Chavan for you, and I would like to introduce Niranjan sir also here. So sir is Professor and Unit Chief, LT MMC and LT MGH Sion Hospital, Joint Treasurer Foxy, President MOGS in 2022-23, Member Oncology Committee, CIFOG, Joint Secretary AFG, Dean AGOG and Chief Content Director of High Grade and FEMAS courses. As I said earlier also, ACE academician couple is here for the task episode series And Komal ma'am, Niranjan sir, thank you so much for conceptualizing this, and thank you so much for making all of us a part of it. And I hand over the dais to you to introduce and welcome our chief guest and guest of honor today.
Thank you so much, Dr. Shehla. I really loved the way you opened and you have introduced. I welcome all the esteemed faculties who have joined. I can see even the panelists, moderator, everything. Everybody have joined. Our esteemed guest of honor, Dr. Alpesh, chief guest, Dr. Alpesh Gandhi, and guest of honor, Dr. Aswath. Well in time, along with all our chairpersons, I can see Sarveshwari Madam, Pratibha Singh, Manoj Chellani, and Jyotsana. Then Anshu has also joined beforehand. So everybody is, Mandira is there. So thank you so much for joining. And today I welcome you for the G episode. G is like we gynecologists. G stands for gynecology. G is there everywhere in our, the logy. There is the logy. G is there. But gestation is the most important. It starts everything with gestation. And there are some gestational disorders which become a chronic disorders in later on, and they have an impact later on. So when we talk about gestational disorder, what comes into our mind is the gestational hypertension, which is the most commonest, and gestational diabetes. And not to forget the gestational trophoblastic neoplasm. So that was the idea behind this episode G. And I thank Dr. Girija Wagh, who is going to speak, our speaker, along with Dr. P K Shekharan and Dr. Manoj Chellani for the moderation of the panel. And now it gives me an esteemed pleasure to introduce our chief guest for today. He's none other than Dr. Alpesh Gandhi. We always say that Alpesh Gandhi is the father of digital foxy. And that is so true. He is the one who has introduced us to this webinar platform, which we are using till today to connect on some topics. Knowledge sharing is definitely going to be there, and webinars are going to be there in some way or the other. And thank you, Alpesh Gandhi, sir, for making us familiar with all these platforms. So, sir has been a Foxy president in 2020, and I was really fortunate to be a chairperson during sir's tenure as the Medical Disorder Pregnancy Committee. He has also been the governing council member of ICOG, past president of Foxy, past chairperson of Practical Obstetrics Committee, vice president of Gestosis India chapter, and he has also been very active as a past president from his parent Ahmedabad Obstetrics and Gynec Society. He is really a resourceful person when it comes to maternal health. I've closely worked and known sir for his Lakshya UNICEF initiative which he has done. He has had so many GCPRs and checklists and immense work he has done. I can go on and on actually, but and his field of interest being the critical care, which has got a benchmark. And when we think about critical care, we resort to Dr. Alpesh Gandhi, sir. So over to you, sir. Sir, please address our audience. Thank you so much.
Thank you. Thank you very much, Dr. Komal, for the kind words and appreciating the work done for the women's healthcare in India by me. Thank you, Dr. Shehla. You are always a very good comparing and compare, and you are always there to communicate with all the faculties in time. And thank you for reminding me for this webinar as well. At the beginning, I would like to congratulate AGOG, Academia of Global Obstetrics and Gynecology, for this wonderful, very, very useful initiative. Very scientific, very academic initiative. I hope lots of delegates who attend this webinar will definitely be benefited. This is a very good series, and you are doing a very good work. So I would like to congratulate all of you for this wonderful and very useful scientific work. Today's topic, yes, episode G, as you have mentioned, episode G, we all are the gynecologists. Of course, episode G means you can say Gandhi also. So this is also for me, this series, this episode. And at the beginning in this episode, I would also like to say hello to my dear friend, Dr. Aswath he is like my brother जो अभी मेले में कहीं खो गया है, अभी मिलता नहीं है, तो I would also like. So it's good. You people gave me an opportunity to meet Aswath on virtual platform. It is very difficult to otherwise meet him. I would like to pay my regards to Dr. P K Shekharan sir, with whom I have worked a lot. Dr. Girija Wagh again, with whom I have worked a lot. And of course, Dr. Manoj Chellani, Madam Sarveshwari Madam Jyotsana, Dr. Pratibha ji, Dr. Monika Gupta, Dr. Priya Vora, another good compare. So it's good to meet all of you and to this wonderful platform. Today's topic is very, very important, gestational disorder in pregnancy, and Komal has rightly mentioned that about these three very, very important gestational disorders. Of course, gestational trophoblastic disorder is relatively less discussed, but it is very, very important. The prevalence may be between 0.3 to 0.5, and sir may enlighten us about more in detail. It may be partial, it may be complete, it may be invasive, it may be an invasive carcinoma. It can different types of, but important thing is age and previous molar pregnancy are high risk, and particularly when age more than 35 or even more than 45 is very high risk category for having this disorder. But the important thing is diagnosis is simple with grayscale ultrasonography and certain tumor markers. But the difficult is not difficult is post management. After post DNA management is very difficult or very important, and we need a close watch, close follow up. And I'm sure since long the topic is not discussed, and today Sir Dr. P K Shekharan sir will highlight all of us about this very, very important topic. Again, as Dr. Komal has mentioned, gestational hypertensive disorder in pregnancy is very, very important. And the incidence of hypertensive disorders of pregnancy increased from 16.30 million to 18.08 million globally in last 2 decades, with the total increase of 10.92%. Worldwide, it is said that every year 76,000 pregnant women die each year from preeclampsia and its related complications, and nearly 5 lakh babies die per annum because of this, because of the complications of hypertensive disorder in pregnancy. Is a major maternal health issue worldwide that is responsible for maternal and neonatal severe morbidity and mortality. And for us, why it is important? Because severe preeclampsia and its complication is the #1 indication for admission of a pregnant woman in obstetric HDU and ICU. Another third very important topic which we are going to discuss today is gestational diabetes mellitus. Again, India is the capital. The incidence is increasing, maybe because of the increasing age, maybe because of the increasing obesity, and of course, so many other reasons are there. But it is said that it is estimated that about 4 million women are affected by GDM in India at any given point of time. And this figures is a wake-up call. This figure is a wake-up call for all of us to place GDM as the highest priority in our public health system. Of course, I'm not going to discuss the complications because of the GTM and the management, because we have very interesting panel for this. But what I would like to again mention is it is well established that the treatment of GDM reduces the risk of serious perinatal complications. Both lifestyle modification and pharmacological therapies have been shown to reduce diabetes development by 50%, and this is also required to reduce NCD in future generation. So it is very, very important to work simultaneously at many fronts, from creating social awareness, creating manpower, training manpower, sensitizing policymakers, updating obstetricians to conduct childbirth in a patient of GDM as per the protocols and guidelines, close monitoring during postpartum period, and regular follow-up for the next few years. And multidisciplinary teamwork is very, very important approach. So much thing we have to work at all these fronts simultaneously. And I've seen medical disorder in pregnancy committee under the able leadership of Dr. Komal Chavan and now Dr. Manoj Chellani. Have seen work, both of them working since long. Komal has worked with me as when I was the president of Foxy. I've seen her working very hard, and I again would like to congratulate her because during my tenure she has worked a lot, and she also won the best committee award for her work also. So I have lots of hope from Komal. I think she will do a lot of work for Foxy in near future, and my best wishes to Komal for all his future plans and endeavors. So with this, I wish grand success to this webinar, and I would like to with you during this webinar. Thank you very much. Thank you.
Thank you. Thank you so much, sir, for your lovely, wonderful, inspiring and encouraging words. It was really great to hear from you. And you have been so closely doing the high-risk pregnancy and critical care. And you have very well highlighted how these disorders are important in our practice. Thank you, sir, for gracing this occasion with your esteemed presence. And now I call upon our guest of honor, Dr. Aswath Kumar. Dr. Aswath Kumar, as we very well known, he was a past vice president of the South Zone for Foxy, and a very dynamic person. He's been a professor and Department of Gynecology at Jubilee Mission Medical College, Thrissur, Kerala. He has done diploma in advanced laparoscopy at France and also at Austria. And he was past Foxy quiz committee chairperson. And I think he has done a fabulous work with the quiz. I think the quiz committee became so vibrant during the tenure of Dr. Aswath Kumar. And he's currently the president of the Karnataka, All Kerala Association and Gynec. He's newly installed, and really honor for you to be among us. And it's over to you to address the audience.
First of all, I thank Komal for inviting me. When as Komal and Niranjan are my close friends, I cannot say no to them, even if I was little busy with some family commitments. And sitting with Alpesh sir, if it was a stage, I would have been sitting on the side of Alpesh sir, always my friend, my mentor, everything. But because of my big commitment, as I taken the president of Kerala Federation, many of you are not seeing me here because I am running around Kerala, just driving from one place to another, no holidays, nothing, all around Kerala. So many social service activities I have taken, tribal care, so many things I have taken. That is why it's a big responsibility. That is the only reason why you are not seeing us. But webinar is a nice occasion to see you all today. I am very fortunate to meet all of you actually. And as Alpesh sir mentioned, Dr. Shehla has punctuality. If you give something to Shehla, she will do it. So she had reminded me 2 hours back so that I was ready. Even if I was traveling, I thought I would stop the car and be there, and I will be listening to you. And thank you. Girija madam is there. So many, Shekharan sir is there, Manoj Chellani, Pratibha madam. So many people are there, and all the respected guests are there. And AOG, yes, AOGO, that is a global, or AOGA, or global organization of Gynec, whichever under Komal who is doing it. It is a great work you are doing, so benefiting so many gynecologists, giving about common topics. Today you can see gestational hypertension, gestational diabetes, and gestational trophoblastic diseases, which everybody should know. As everything Alpesh sir has mentioned, what are things, I'm not taking a lot of your time. Komal, whatever she takes, we know that medical disorder committee, she does it in a big way, and it will be so many programs, and she's a very efficient person in doing whatever work she does. So I wish her all the best for all the future endeavors, whatever she is taking. So thank you once again for inviting me for this webinar and being the guest of honor. And it's a great honor always with all the seniors to be there as a great honor to me. Thank you. Thank you so much, Komal. All the best for all your programs. Thank you.
Thank you. Thank you so much, Dr. Aswath sir. And thank you, our esteemed chief guest and guest of honor. And now we begin with our scientific program, and I hand over to Shehla.
Thank you so much, respected Alpesh sir. Thank you so much, Ashwath sir, for encouraging us always, as we have seen the dynamism of Alpesh sir, and it is still continuing. So we seek your blessings for every future endeavor of ours. So with taking permission from Komal ma'am, I would like to start the scientific session by introducing chairperson for the first session, Dr. Pratibha Singh. Ma'am is consultant laparoscopic gynecologist and IVF specialist, director, Healing Touch Hospital, Bhagarpur. She is chairperson of International Academic Exchange Committee of FOXI currently. She has been the chairperson of Fertility and Aging Committee. Oh, she is still the chairperson of Fertility and Aging Committee of Indian Menopause Society 2023-24, and that calls for a wow, ma'am. And President Bhagalpur Menopause Society, Vice President of AOG SBJ. She has done added multiple laurels to her cap, and we look forward to learn from you more, ma'am. And secondly, I would like to introduce the next chairperson for the session, Dr. Monika Gupta. Komal ma'am, she has taken some excuse. Ma'am is busy in some emergency, so maybe please request Pratibha ma'am to take over for this session.
Okay.
Okay.
Thank you.
Ma'am, please introduce our speaker for first session. Girija ma'am is joining. She's just connecting to her audio.
Okay. So first of all, thank you so much, Dr. Shehla, for introducing me. And I also want to thank Dr. Komal for including me in this program. And really, I'm really honored that you have taken me in your series. And I wish you all the best for your future endeavors. And my respectful regards to Alpesh Gandhi sir, our chief guest for this webinar, and Dr. Aswath Kumar. And I can see Dr. Sarveshwari madam, then Dr. Archana, Dr. Manoj. So all of you, I just want to say hello to all of you. And it's my proud privilege to introduce Dr. Girija Wagh madam. She is gynecologist. She is a IVF specialist, and she is the professor in the Department of Obs Gynae, Bharati Vidyapeeth Medical College Hospital, Pune. And she's a senior consultant, Cloud9 Apollo Hospital, Pune. And you all know she is also the vice president of Indian chapter of Gestational and member governing council ICOG. And also she has been now the vice president of FOXI, if I'm not wrong. So I think that has not been written in her CV. So that should be included in the CV. So madam, welcome to this forum, and I'll request you to start your talk, madam.
Thank you so much for that very kind introduction. And thank you, Komal, especially for making me a part of this wonderful Academia of Global Obstetrics and Gynecology. It sounds so much like ACOG, but yes, we have an AGOG here. And what a wonderful thing. I never thought that we can bring in gestational hypertension with gestational disease. I can see Professor P K Shekharan, who has been my mentor in many ways. And without much delay, I think we will speak on, and I discussed this with Dr. Komal. And my task is to only limit myself to gestational hypertension, as I understand, Komal. And that is where we'll be targeting this talk in the next about 15 to 20 minutes. So thank you for that kind introduction. And as we say, gestational hypertension and preeclampsia, eclampsia are hypertensive disorders, both resolve postpartum. And gestational hypertension happens to be the commonest cause of hypertension in pregnant women. And if you look at it as a clinical diagnosis, basically, and defined by the new onset of hypertension after 20 weeks of gestation, when the blood pressure records from 140 to 90 or more mills of mercury, and in the absence of any proteinuria or end organ involvement. So it's just a pure hypertension. Really, since it's called as gestational because it's typically seen in pregnant women after 20 weeks of gestation. When we classify the hypertensive disorders, there are chronic hypertension, preeclampsia, eclampsia, superimposed preeclampsia, and gestational hypertension, which probably can be the only term used for PIH, because PIH is used very generally. And if you ask me in the current definition, only gestational hypertension will be appropriate to be called as pregnancy-induced hypertension. There are other things also, such as transient hypertension of pregnancy or chronic hypertension identified in the later half of pregnancy, but gestational hypertension typically will be associated with pregnancy. So blood pressure, when it's documented at least on 2 occasions, at least 4 hours apart, and the ones which will record more than 160 or 100 mills of mercury would be called as severe hypertension. And the dictum today, priorly and globally and universally, in any hypertension diagnosed as 140/90 or more, mandates an antihypertensive treatment. There is no doubt or no query about it, because we have the CHIP study and the CHAP trial, which have both told us that this is important. Now, management of GHD with severe hypertension is identical to that for preeclampsia with severe features, underscores the potential for serious adverse events in when pregnancy-induced blood pressure are severely elevated, and even in the absence of proteinuria or new signs of end organ dysfunction. So we have to be careful whenever we have made a gestational hypertension as a provisional diagnosis, because we probably have yet to diagnose this patient. Clinically, you have seen only the hypertension, so that will be a working diagnosis. But if she happens to have proteinuria diagnosed by any other means, or if you find that she has any of the systemic involvements, which usually will be unveiled only after doing laboratory tests or maybe clinical assessment of pulmonary edema, or maybe looking at her visual disturbances, or what we typically have been classically calling as signs of impending eclampsia, then this would not be gestational hypertension, it would be preeclampsia. So we have to be understanding that this difference has to be made. So gestational hypertension, till we rule out all of these things, will continue to be the working diagnosis. Now, therefore, the diagnosis always has a potential to change. Preeclampsia, if there is proteinuria, signs of end organ dysfunction, if there is any documentation of blood pressure elevated before pregnancy or which remain persistent for more than 12 weeks post-pregnancy, and whenever we find that there is a hypertension, all these differentials have to come to our mind. Now, there are certain important timelines and important cutoffs that we have to remember. Normal blood pressure is when the systolic blood pressure is 120 mills of mercury and diastolic is 80 mills of mercury or less, while elevated blood pressure would be 120 to 129 mills of mercury, systolic blood pressure, and diastolic of less than 80. Hypertension is also divided into 2 stages. Stage 1 is systolic 130 to 139 mills of mercury or diastolic 80 to 89. And stage 2 is systolic at least 140 mills of mercury or diastolic at least 90 mills of mercury. And the transient hypertension of pregnancy, where the BP returns to normal by 12 weeks of postpartum, has been diagnosed only once sometime and never ever again. So these are the various definitions which we should be aware of. There is certain important facts. Pre-pregnancy blood pressures for comparison with blood pressures during pregnancy may not be available or may be available. Undiagnosed pre-pregnancy hypertension, which may be in the severe range. Prenatal care early in gestation may have normal or mildly elevated blood pressures because of normal early pregnancy physiology. Development of isolated severe hypertension later in pregnancy may reflect return to their baseline blood pressure level rather than preeclampsia with severe features, and usually present late in gestation for prenatal care, especially some women would not have access to care and have isolated severe hypertension. It is difficult to determine whether this reflects the chronic hypertension or is the development of preeclampsia. If severe features are there, naturally it will be preeclampsia, or whether it is gestational hypertension. Since the management and pregnancy outcome of chronic hypertension is different from the management and pregnancy outcome of preeclampsia with severe features, the distinction is clinically relevant, but not always possible many a times during pregnancy. Now, what we have to remember also is the postpartum continued assessment and the surveillance of these patients, because all patients require postpartum follow-up at least till 12 weeks of gestation to establish whether they had the PIH or have chronic hypertension with or without superimposed preeclampsia. And all these diagnoses are important because each one of them have a long-term health implications. So when we look at the prevalence, the most common time of hypertension, as I mentioned, in 6 to 17% of healthy nulliparas, 2 to 4% of multis, and the prevalence is highest in pregnant women with preeclampsia in a previous pregnancy, multifetal gestation, or obesity. A study was conducted in southern part of our country, which showed a prevalence of gestational hypertension to the tune of nearly about 47.4%, preeclampsia 33%, chronic hypertension 8.2%, and preeclampsia superimposed on chronic hypertension nearly 12%. So what are the risk factors? They're similar to preeclampsia, and epidemiological studies report differences in the magnitude of the associations for the two disorders. And therefore, everything that we talk of clinical factors that have been associated with an increased risk of developing preeclampsia, such as nulliparity, age, family history, chronic hypertension, and maybe history suggestive of hydrops fetalis, racial, ethnicity, poor control, hyperthyroidism, and fetal growth restriction. Many times you'll find that growth restriction first and then the hypertension will be seen clinically. And there are certain male partner related factors such as the new partner or limited sperm exposure, IVF or pregnancies, especially the ones with oocyte donation, and elevated blood pressure level, post-traumatic stress disorders. So many reasons can be there responsible for causing hypertension. So the diagnostic evaluation goals are confirm the elevated blood pressure and exclude the white coat hypertension, distinguish gestational hypertension from preeclampsia, which is a different course and prognosis, and determine whether hypertension is severe, which affects management and outcome. Now, newly diagnosed hypertension, white coat hypertension, should be excluded by repeating measurement of blood pressure when the patient is relaxed. Results of home blood pressure monitoring can be useful to establish the patient's blood pressure profile. The challenge can be an improperly calibrated machine and a technique. Approximately 30% of pregnant participants in a trial of self-blood pressure monitoring had discordancy between the home and office readings, and most of which were attributed to white coat hypertension. Now, additional evaluations would be proteinuria. And sometimes if you do a urine dipstick, it may come negative. You can go ahead when you're seeing the signs, you could say, probably then do a urine protein creatinine ratio, which can act as a sensitive spot test, evaluate for features of severe disease, rule out other causes of acute hypertension. There can be essential hypertension due to various reasons, lab investigations, determine the severity, and assess the fetal well-being. So the question comes, is this gestational hypertension or preeclampsia? And false negatives will be TRES 1+, repeat low specific gravity, and high salt concentration, highly acidic urine, and non-albumin proteinuria. And as I mentioned, protein creatinine ratio of more than or equal to 0.30 milligrams protein by milligrams of creatinine on a random urine sample or with a 24-hour urine collection will tell you that there is proteinuria. Now, the confusion can still be tough with P exclusion can be there, and 10% of pregnant patients with clinical and or histological manifestation of preeclampsia have no proteinuria, and 20% of those with eclampsia do not have significant proteinuria prior to seizure. Hypertension, if accompanied by any of the signs and symptoms of end organ dysfunction, the patient should be managed as a patient with preeclampsia, despite there not being any evidence of proteinuria. So evaluation for features of severe disease can depend on new onset of cerebral or visual disturbances, epigastric or right upper quadrant pain. The chest should be auscultated to assess the pulmonary edema, and we have to then label it as preeclampsia with severe features. Now, sometimes other causes of acute hypertension can be there, and one has to rule out the medical disorders such as pheochromocytoma, use of drugs that can produce hyperandrogenic state like amphetamines, phencyclidine, and cocaine, and a standardized interview to screen for misuse of substances should be performed. Nowadays, we don't call it as substance abuse, but you say that substance misuse disorders, and that have to be understood. And especially in our country, tobacco is quite a lot used by women, and even smokeless tobacco is what is our challenge, which we must investigate. In order to define the end organ involvement, that preeclampsia, but not with gestational hypertension, changes consistent with preeclampsia would be thrombocytopenia, creatinine concentration being more than 1.1, serum transaminase concentrations or LFTs being more than 2 times the upper limit of the normal range would make us suspect that this looks like preeclampsia and this is not gestational hypertension, but this requires to be ruled out because severe features is the current diagnosis at the ISSSP by 2014, that even if there is no proteinuria, you must look for these features so that it will differentiate it from gestational hypertension. So determining the severity depends numerically on the blood pressure record. And whenever the blood pressure is more than or equal to 160 by 110 units of mercury, it is taken as severe hypertension. Biophysical profile or non-stress test with amniotic fluid index should be done for fetal well-being. Additionally, look for biometry for the baby's weight and whether the baby is small for gestational age. And umbilical artery Doppler velocity, if they are reversed, then it will tell us that this is a fetal growth restriction. Now, whenever we are looking at GHT, remember that it also has a risk of progression to preeclampsia, and it probably could be the first step into preeclampsia because nearly 10 to 50% initially diagnosed GHTs will have preeclampsia in 1 to 5 weeks. From progression from preeclampsia to preeclampsia with severe features would be rapid within days. Unanswered questions are GHT and preeclampsia. Are these independent diseases with a similar phenotype, that is hypertension? GHTs and early mild stage of preeclampsia, are they the same? Consistent evidence preeclampsia develops in many initially diagnosed gestational hypertension, and those who progress to preeclampsia have peculiar characteristics. So, who will progress to preeclampsia? Gestational age less than 34 weeks at diagnosis, sensitivity is 85% and specificity 60%, mean systolic blood pressure of more than 135 on 24-hour BP record, sensitivity 61%, specificity 76%, increased serum uric acid more than 5.2 is predictive of progression to preeclampsia with an 88% sensitivity and 93% specificity, and abnormal uterine artery Doppler velocimetry is predictive of progression with again a good sensitivity and specificity. And there are certain non-readily measurable things such as elevation of the anti-angiogenic markers such as the SFLT1, reduced levels of pro-angiogenic placental growth factors, and higher total vascular resistance of more than 1349 seconds per centimeter raised by 5 would be something that can be done in an experimental level, but we can always consider doing an SFLT PLGF ratios in these women. In my personal clinical practice, I have found that many times just being astutely clinically identifying conditions and doing a proper recce on the patient usually gives you a guidance that this is developing into preeclampsia. Preeclampsia and GHT are independent diseases, although they share many risk factors. Epidemiological studies report differences in the magnitude of the associations for the two disorders. And what are these factors? If you look at GHT, it will be typically found in multis, while preeclampsia is a disease of primiparas. Gestational order will increase the risk factor for preeclampsia. Diabetes mellitus, possibility of preeclampsia is more. Recurrence rate in GHT is 20% with preeclampsia. It would be 5%, especially with preeclampsia at term. Total blood pressure, blood volume would be much more reduced in preeclampsia. Total plasma volume will also be much more reduced in preeclampsia. Doppler measurements of arterial and venous hemodynamics and the vascular endothelial function would be abnormal in preeclampsia. Levels of microparticles associated with endothelial cell damage will be markedly elevated in preeclampsia, while will be significantly lower in GHT, and placental ischemia on histopathology will be less prominent in GHT, while it will be overt in preeclampsia. So these are some clinical factors which we can definitely look for. And then there are others which are interventional factors, out of which are doable for us would be the endothelial cell damage, like SPL-PLGF ratios, and then maybe looking at the Dopplers. So management depends on the timing of the delivery and the occurrence of the GHT. Balancing the three competing factors is important. So fetal benefits from expectant management are seen, so fetal growth and maturation, maternal and fetal benefits from early interventions, avoidance of complications from progression of HDP over the remainder of pregnancy. Maternal fetal risks from expectant management would be progression of HDP and possible sequelae, including stillbirth or asphyxia. And these conditions therefore require proper surveillance and monitoring. So surveillance of pregnancies with non-severe GHT managed expectantly can mitigate the risk of development of serious sequelae of GHT, manage these patients expectantly, and deliver them when the clinical situation deteriorates or when they reach term. Now, if you look at the Hypertension 2 trial evidence, which we have always oft been quoting, randomly assigned patients with non-severe hypertensive disorders of pregnancy at 34 to 36 plus 6 weeks to immediate delivery or to expected management with delivery at term or upon development of features of severe preeclampsia, 3% of patients with GHT, that is new hypertension, diastolic blood pressure more than or equal to 100 millimeters of mercury with no proteinuria, the expected management developed one or more adverse maternal outcomes, such as thromboembolic complications, HELP syndrome, eclampsia, and placental abruption. Immediate delivery group had no maternal adverse outcomes, but immediate delivery landed many neonates in RDS 4.3 versus 1.1%. Long-term pediatric follow-up at age 5 has shown that neurodevelopmental outcomes were not significantly different between the immediate delivery and the expected management groups, and blood pressure less than 160/110 of mercury, the management should be like that of preeclampsia without severe features. So hospitalized and home care, most pregnant women, GHT without severe blood pressure elevation can be managed safely as outpatients with weekly or twice weekly office visits, and to assess the maternal symptoms and fetal well-being, measure blood pressure, protein excretion, platelet count, serum creatinine, and transaminases, and home BP monitoring can be useful to determine the average and the peak blood pressure during the usual activity. It's important to educate the patient about the signs and adverse things and what they are into, and that can help us making them party and cooperate with their own condition, and of course have a proper surveillance for fetal movements. Emergency reporting systems have to be taught to them, especially when there'll be heavy vaginal bleeding, severe headache, stroke, severe breathing problems, sudden severe pain, and if there is any kind of a life-threatening emergency. What about bedroom and ambulation? It's important that the women are not absolutely confined to bed, because that cannot be very safe to them, and they should not do so much of work that they will be extremely exhausted. So one must individualize based on the patient's need. And low-dose aspirin in GHT is another question that we have in mind. Whether LDA prevents progression of GH to preeclampsia is unclear. Beginning of low-dose aspirin in second trimester, moderate decrease in preeclampsia and sequelae have been observed, and practice guidelines consistently recommend initiating LDA before 20 weeks, and our gestational hypertension gets diagnosed only after 20 weeks. Preeclampsia is known to affect placental development early in pregnancy. So ACOG says serial BP at least 1 in office measurement, weekly assessment of proteinuria, platelet count, serum creatinine, and liver enzymes, and proteinuria, thrombocytopenia, and all these transaminases would help us in changing this diagnosis from GHT to preeclampsia. Fetal surveillance would be also done based on daily fetal movement count, and one can do serial ultrasounds and Dopplers if they are necessary. And this also will have to be individualized based on the severity of the gestational hypertension. And the antihypertensive medicines, as I mentioned at the outset, today the GHT consistently above 140/90 of mercury, we have to start them on antihypertensive medicines, because Mothers are definitely important for us. And if we are finding a delivery going to be imminent anytime shortly, you can give them antenatal corticosteroids if they are going to be delivering. And ideally, it's always better to deliver GHTs the moment they cross over to 37 weeks of gestation. So this is what about the timing of delivery is concerned. When you have an uncomplicated GHT, you may consider maybe 38 to 39, but you are not going to gain much advantage. So once she has reached the 37 weeks maturity, for the want of unnecessary surveillance and early IUDs, it's better that you deliver them. Consortium on safe labor between 38 and 39 weeks of gestation achieved the optimal balance of low maternal and low neonatal morbidity and mortality, when the GHT BP more than 160/110 deliver at 34 weeks after maternal stabilization, and in expectant management until 37 weeks is not advised in very severe gestational hypertension. Intrapartum, put them under similar surveillance as you would do for a patient of preeclampsia. And if the GHT develops any kind of severe features during delivery, definitely give prophylactic magnesium sulfate. So this looks like a very, very sort of a busy slide, but this only mentions that severe GHT have rates of pregnancy complications compared to those with preeclampsia and severe features, and thus ACOG recommends managing these patients similarly by giving them magnesium sulfates and antihypertensive medicines. If you look at the maternal prognosis, the mean time to normalization of BP postpartum after preeclampsia is approximately 2 weeks, and the slower rate recovery in preeclampsia may reflect the time required for resolution of the endothelial injury, which may not be present in gestational hypertension. So they may revert back to normal blood pressures immediately. And postpartum course normotensive within first postpartum week, BP returns to normal by 12 weeks postpartum, the diagnosis changed to transient hypertension pregnancy. Remain hypertensive at the 12th week postpartum, you'll have to label them as chronic hypertension. And the meta-analysis of individual patient data from 24,000 GHTs found that 22% developed hypertension in subsequent pregnancy, 15% had gestational hypertension, and 7% had preeclampsia. So it's wise to start them on prophylactic low-dose aspirin if they have given such a previous history in their previous pregnancy. Remember, the long-term prognosis is similar to any hypertensive disorder where these women can have a lifelong cardiovascular disease, dyslipidemia, diabetes, similar to patients of preeclampsia. And perinatal outcomes in GHT would generally be better than preeclampsia, but then we have to be taking care of babies who are fetal growth restriction preterm in a similar way. So in conclusion, please remember this classification of hypertension, and also remember that each one of them have a risk of developing that terrible disease which we are always scared of, and that's called as preeclampsia. And gestational hypertension will always have a 25% possibility of going into preeclampsia. So this is one Gestosis score which the Indian chapter has promoted and we all are aware of, which is an easy clinical tool to help us identify the risk factors of these women. And these are categorized based on each of the features that have been mentioned here. And accordingly, you can approach these patients. And if the women are at risk of developing hypertensive disorders, advise them moderate exercise of more than or equal to 140 minutes per week, which will cause 40% reduction in preeclampsia. Assess their high risk for preeclampsia, start them on low-dose aspirin before 16 weeks, which will reduce the preterm preeclampsia. Give them proper calcium intake and plan timed birth. And this is from the recent publication of the New England Journal 2022. Be very sensitive to the signs of preeclampsia and the severe disease, and do not relegate GHT because it is a disease probably in transition, and that is what we have to remember. Thank you so much for giving me this screen time, and I hope I have been able to make justice to the topic that was allotted to me.
Excellent, madam. It was a wonderful talk. It was a comprehensive full about the gestational hypertension. And you very rightly said that 140/90 millimeters of mercury blood pressure requires antihypertensive treatment. That is, we all should remember this. And I think this should be propagated more, because in many places, people, they don't write antihypertensive drug at this level. So that has to be told to even to many of the gynecologists, they are not knowing that. So that is very important that we must propagate this. And also you told about the difference between preeclampsia, that there is proteinuria with end organ function, which mainly labels that. And what is chronic hypertension? After 12 weeks, if it is continuing, that means she has been suffering from chronic hypertension. So very well, you have told everything about the management, evaluation, exclusion criteria. Then also you have told about the clinical features and interventional factors, which is important. And the most important thing is the counseling for the patient, that home monitoring is also important. Patient should know what is the importance of taking their blood pressure. So they should be taking blood pressure at home, and whenever there is some emergency, they should report to doctor. That is again very important thing which you have told. Then about the low dose aspirin also you have told, and we all know, and that should again be told to everyone. All the periphery doctors should know that that is also can be given, and many a times that is the only treatment we give, and the patient has a very good benefit by that. So it was very well covered, madam, and I think nothing has to be included in that. So thank you so much for giving me this opportunity, and thank you. Thank you.
Thank you so much. Thanks, Sitan.
Thank you, ma'am. Komal, ma'am, we request you to give kind comments.
Yes, what can I say? It was such a comprehensive and everything was so well covered with great take-home message. And as usual, Dr. Girija Wagh has done a complete justice and covered the topic so well. So thank you so much, Dr. Girija. It was real great pleasure, and I think the viewers, everybody has benefited, because this problem becomes in our day-to-day practice. You know, we'll have every 4th or 5th patient in a day. You see patients coming with high blood pressure in pregnancy. So thank you so much.
And many a times in our place, what we see, patient has been referred to the physicians. So that should not be done.
That should never be done.
So it is very important that we must also start knowing that what all we can give and how far we can treat these patients. So that is, and very simple way you have explained. That was the best thing. Thank you so much.
Thank you so much.
So thank you so much, Pratibha ma'am. Thank you so much, Girija ma'am. And just one word for you, word ni line. We all love you. We just simply love you for the way you teach.
Thank you.
Kya baat hai, right? So thank you so much, ma'am, for being here. Thank you so much, Pratibha ma'am, for flawlessly conducting this session. And thank you so much, Komal ma'am. And we take your permission for second session.
Yes.
Okay. So Dr. Priya, our beautiful co-anchor for today, the session is handed over to you. All the best.
Without delay, we will start the session 2. May I request, the CV of Dr. Sarveshwari Nautiyal. Madam needs no introduction, but as a formality, I will introduce her CV. She's a founder and managing director of Kishori Foundation, and an NGO which has focused on conducting screening programs and awareness camps in rural and urban areas of Uttarakhand for early detection of breast and cervical cancer. She's a director at the Medical and Health Services, Government of Uttar Pradesh. And Madam is even a senior consultant, director and colposcopist at the Regional Cancer Detection Center at Sapru Hospital, Allahabad. And she is a member of the Breast Committee of the FOXI, and she's a faculty at various state and national conferences. Her fields of interest is early detection of breast cancer and cervical cancer. And she's important in conducting a lot of the screening camps on even the thyroid disorders. May I have our next person, chairperson CV, please? Yeah, Dr. Jyotsana Daule. She is a president of the AOGS, gynecologist and obstetrician of Daule Hospital, Ahmednagar. Obstetrician, she's an obstetrical and gynecologist and an infertility specialist at the Matratva Test Tube Baby Center for over 22 years. She has started the first IVF center in the district 12 years back and has delivered the first frozen embryo baby. Past organizing chairperson of AMOGS in 2016. I would request both the chairpersons to introduce the speaker for this session. Thank you.
Hello.
Yeah. Dr. Sarveshwari Nautiyal, ma'am.
Good evening, everybody, and regards to Dr. Alpesh Gandhi, chief guest today, and Dr. A. Kumar, guest of honor. I just want to thank Komal for giving me this opportunity to be here for this great academic feast. It's true. This is an educational series, and all will be going to be benefited by this. It's great. The name is very catchy, AGOG. So, Komal, you are going to educate everybody globally. It's a great moment for me to introduce a very senior person. Can I have very senior person, Professor Dr. P K Shekharan. Sir, we have heard about you. We know you very well. But it is difficult for me to introduce you because I know a teacher is always a teacher. A word coming out from the teacher is an educational feast. Everybody learns something from you. Sir is retired from Calicut as a professor of OBGY in 1999 and worked in MAS Medical College as a professor of obstetrics and gynae during 2003 to 7. He is president of National Society for the Study of Trophoblastic Disease. Very important, sir, subject, sir. And he was vice president Foxy, member of governing council, International Society of Study of Trophoblastic Disease. He was the president of Kerala Federation of Obstetrics and Gynecology in 2003, and he has lots of publication. I can understand, sir, being a professor in a medical college, you must be having a lots of this publication. And Foxy ICGO recommendation for good clinical practice got the prize for that. Still, he is doing research activity, including the study of trophoblastic disease, hyperinsulinemia, and insulin resistant in PCOS. Nice to introduce you, sir, and we are lucky to have a word, and really it will be an academic feast for all of us, including all the seniors, all the juniors, and everybody who is listening here. You are welcome, sir, and the topic which you are going to discuss on today is GTN. It's management. You really simplified it. So sir, you're welcome to start your talk.
Thank you, ma'am. Thank you for that kind words. Thank you, Komal, for the kind invitation, and wish you all the best. Respected senior colleagues, can you see my slide? Is the slide is visible?
Yes, sir. Yes, sir.
Oh, okay, thank you. So, gestational trophoblastic neoplasia is one of the most curable of all the gynec malignancies. But still, we get patients coming at a very late stage where you may have to do multiple courses of multi-drug therapy with a lot of toxicity and all. The cases following hereditary form should not be missed like this. That is one important thing. But unfortunately, the cases that are following a full-term delivery or an abortion, we may not anticipate, and we may miss it, and they may come at a later stage. So it is an eminently curable condition, curable cancer. Not only that, it is with the cure, you may even preserve the reproductive potential of that girl. Usually they are young patients who haven't completed their family. So in spite of having a cancer, you can treat and get a cure and also preserve their reproductive function. This is all because of one of the important thing is that there is a very sensitive tumor marker, the HCG, and also there are very effective chemotherapeutic agents, even in widespread metastatic disease, you can achieve almost up to 90% of success or cure in such condition. So that is what is the importance of diagnosing it early and saving the girls and preserving their reproductive function. Okay. So GTD means there is pre-malignant conditions of complete and partial hereditary mold. Also, that is gestational trophoblastic disease includes the malignant ones also, like invasive mold, choriocarcinoma, placenta-site trophoblastic tumor, and epithelial trophoblastic tumor, which are all very rare. So the malignant varieties are put together as GTN or gestational trophoblastic neoplasia. So this has been very difficult to understand initially, but beyond 1950s or 1956, actually, the first cure of a metastatic choriocarcinoma was achieved by methotrexate, and that was the beginning of the medical oncology, so to say. Now, there's no doubt in making a diagnosis of hereditary mold by ultrasound if you happen to see a patient beyond 10 weeks, at least beyond 9 weeks. Because below 9 weeks, the characteristic finding of a vesicular mold under the ultrasound scan may not be there. This is typically a snowstorm appearance that we see in a well-developed molar pregnancy, complete mold, without any evidence of fetus. Maybe there are 20 to 30% of them may have bilateral cyst, that thigaloutian cyst, maybe up to 6 to 10 centimeters size. And in a partial mold, you will have a fetus with a part of the placenta showing the molar change. And hence, there is no difficulties. And the vesicular mold, once you evacuate, usually there is no doubt, but you have to send it for histopathology. Now, the present day, the problem starts. The patients, when they miss a period, most of them will have a pregnancy test done, and they may think that they are pregnant, maybe 7-8 weeks, and they may have a scan also done. And that is the place where you start the problem. Because the patient may come even with a scan report of a failing pregnancy, like missed abortion or unembryonic pregnancy, or missed abortion, and you may usually advise a medical abortion. And they may take the medicine, they may abort at home or outside the hospital. There is no tissue available for histopathology. It might have been a vesicular mold, and without follow-up, she may land up at a later stage. Some of them may be landing up at a later stage with advanced disease. About 15% of the patients may develop the invasive mold, and 3 to 4% to choriocarcinoma even. So about 20% of them will have the problem. 80% will not have any problem after evacuation. So that is a problem nowadays. We are seeing that patients are coming very early, eager to know what is whether they are having a normal pregnancy or so. And on scan, you may not get the classical finding of a molar pregnancy. It goes as a missed abortion. She has an abortion without histopathology of the product, without any follow-up. And it's seen that even if you remove the molar tissue at an earlier stage, the potential for developing malignancy is the same. So they don't escape from the development of molar gestational trophoblastic neoplasia, even if it is getting aborted early. Now, this is a patient who had come to us. The first picture on top, you can see, you can't make clearly a diagnosis of molar pregnancy there. She was advised admission and evaluation, but she could not come there. But later on, after 2 more weeks, nearly 9-10 weeks, she comes with a severe nausea vomiting, and the scan shows the typical molar change. The same patient. This is the thing which I was telling, that earlier scan may miss an early complete mold, because classical finding of a snowstorm appearance will take beyond 9 weeks or 10 to 12 weeks to see the classical finding. But nowadays, they all want to know what they are having, and we may do a scan And then the scan may be like this, and you may miss the diagnosis of a molar tissue, molar pregnancy, and she will have a abortion at home or outside the hospital, and no question of following up. So this is what is happening, and what is the solution there? Thing is that in any type of an abortion, whether you are evacuated, whether even if it is an MTP done, better to have a urine pregnancy test done after 4 weeks of a evacuation. In a normal delivery, you can see the first line is, you can see, sorry, the with a HCG in the urine will disappear within 4 or 2 weeks. The first line, time pregnancy, the beta HCG becomes negative in urine within 2 weeks. If it is an induced abortion, maybe it is taken 3 to 4 weeks. So there is no chance of having the urine pregnancy test positive beyond 4 weeks. In any abortion, even if you are not able to do the histopathology of the product, please do a urine pregnancy test after 3 or 4 weeks. And if it is positive, please follow the case, because that could have been a missed, vesicular mode, which was missed, and later on she may develop. So that is the only way to pick up, even if you are not able to do the histopathology of all the abortion, which is impossible in our country. So we have to be practical. So practical solution for not missing such a case is to do a simple urine pregnancy test after 4 weeks. Now presentation. So presentation with hypertension, hyperemesis, and other things with vesicular mode is rare now. As I said, people come very early. It was in our earlier time of our practice. People were coming not below 16 weeks or 14 weeks. By that time, it would have been a 20-week size uterus if it was a vesicular mode. Till such time, people were not coming. And there was no doubt in making a clinical diagnosis. And with the availability of the ultrasound, it's all become clear. And we will be following those cases. So nowadays, it's not happening. If a patient metastasis with coming with the colorectal carcinoma following a normal delivery, unfortunately, we may not anticipate, and they may come with severe symptoms later on with the metastasis. So those patients cannot be helped, but more than 50% of the colorectal carcinoma or GTN develops following adaptive form mode. So try to follow those cases and pick up, and so that we can get 100% cure. So following vesicular mode, the important thing is to follow with the HCG. Now, HCG is done every week till it has become negative, probably 2 or 3 more tests, and then once it is negative, follow with once in a month till 6 months. That is all. Not to have a very prolonged period of follow-up, which is really, for the patient, it will be really worrisome. She is told that you may develop cancer. It's all very difficult for the patient. So don't have 1.5 year, 2 years follow-up like that. If the patient becomes, HCG becomes negative within 8 weeks of an evacuation, she requires only 6 months follow-up from the date of evacuation. Please be sure about it, because once it has become negative, there is very, very, very unlikely chance of a rise in HCG later on. So the follow-up in such cases can be completed within 6 months. If the wound takes more than 8 weeks, probably you may require an year of follow-up, but it is 6 months from the date of negative HCG. The other first one, if it becomes negative within 8 weeks, 6 months from the date of evacuation. That's all what is required. If it takes more than 8 weeks from the date of HCG negative, another 6 more months, which may be around that time. So we will pick up all those cases. Now, the diagnosis of GTN is a rise in HCG of 3 values over 2 weeks. A rise in HCG is more than 10% of the previous value. And if you get that, you make a diagnosis of GTN. That means you make the patient eligible for chemotherapy. No histopathological confirmation is required, but this gives the diagnosis that she is having GTN. If there is a plateauing over 3 weeks with the 4 values, which is a fall less than 10% of the previous value. If you get such values for 4 values or a period of 3 weeks, that's a case of GTN. Again, start treating the patient. Persistence of the HCG 6 months after evacuation is taken as a sign of GTN and she requires chemotherapy. If you happen to have that tissue diagnosis, again it is GTN. So this is the simple way of making a diagnosis of GTN, which doesn't require any histological confirmation. In fact, this is the only cancer where you start chemotherapy on the level of the marker. But once you make a diagnosis of GTN like this, then you have to have a workup. Now, the treatment of the GTN depends on the stage and score of the disease. So once you have made a diagnosis of GTN with the following molar pregnancy evacuation by the HCG, then you have to do you cannot just start the treatment. You have to, the treatment depends upon the scoring, risk score, for which you have to do a metastatic workup, which is pelvic ultrasonography with the Doppler, chest X-ray, maybe CT scan is better because chest X-ray may miss. When there is a lung metastasis, then you have to look for other sites like MRI, brain, CT abdomen, liver, and everything. So this is the simple algorithm. Once you get the diagnosis of GTN by the HCG follow-up, make a metastatic workup. If there is chest involvement, then you go beyond. That is, you have to go for brain, liver, and other things further. But if there is nothing in the chest, you can take it as if there is no metastatic spread and start making the treatment. So that is the simple way of seeing this. So once you make a metastatic work, the pelvic ultrasonography with the Doppler, you can see the highly vascular nodule on the uterus with the highly vascular Doppler study. There can be chest showing a nodule on the chest, or there can be suburethral nodule sometimes. So you have to see the clinical examination and also look for the metastatic sites. And if there is lung involvement, then you go for liver, brain, and other thing. If the lung is not involved, stop it there. No further thing at that time. So this is the workup. Post-IDAX for mold, pelvic ultrasonography, chest X-ray. If it is negative, then you stop it there. If chest X-ray is positive or a CT scan is positive, then you have to go in for MRI brain, CT of the liver, and other areas. If the GTN is diagnosed following delivery, abortion, or ectopic, then you have to do pelvic ultrasonography with the Doppler, CT chest, MRI, liver, brain, everything. So if it is following a delivery, you suspect diagnose GTN, you have to have full workup and have a staging and scoring. So the treatment depends upon the stage and the score. Once you have made a diagnosis of GTN by HCG follow-up, you have to do the workup, you have to have the scoring done. You cannot start the chemotherapy by just diagnosing. You have to group, because if you start single agent therapy for a high risk case, you are going to make that case resistant for chemotherapy and you are going to not to get the cure of for the patient. So that's why you have to have the scoring done. Then decide on the type of chemotherapy, whether single agent or multi-agent. So FIGO stage is confined to the uterus, is stage 1, extending outside the uterus, stage 3 to the lungs, and stage 4 other metastatic stage. Simple thing. What is important is the FIGO risk scoring, which is a modification of the WHO score, which was taken from Bakshaw's risk scoring. It was Bakshaw who has put these factors as affecting the cure of the condition. The treatment of the condition depends upon the type of drugs, whether it is multi-agent or single agent, depending upon the score. So you've got certain prognostic factors like age in years, antecedent pregnancy, whether it was following a mole or abortion or term pregnancy get more score. Interval between the months, within 4 months, beyond 4 months, and beyond 1 year. So accordingly, you have to give the score. HCG value of the HCG, whether it is 1,000, less than 1,000, or more than 1,000 to 10,000, 10,000 to 100,000, like that. The level of HCG also is taken into account. The tumor size, the metastatic site of the metastasis, the liver and brain are given the maximum score of 4. It was not there in the WHO scoring, it was not given that high score, but the figure scoring, which is modification of the WHO, gives the maximum score for the brain and liver metastasis. So also the failure of prior chemotherapy, 1 drug and 2 drug, multi-drug therapy. So we have to have the scoring done. Then only decide on the treatment. The treatment is decided on them. So treatment depends on the stage and risk score. Stage 1, 2, 3 with a risk score of 6 and below is low risk, and you can start single agent. It's a simple mathematical derivation. Stage 4 or risk score of 7 to 12, which is high risk, and you start multi-agent therapy. Now we have now included what is known as the ultra high risk. A score of 13 and above is taken as ultra high risk to differentiate, because these patients, when you start the multi-agent therapy, they all die within 4 months because of certain complications, and hence to avoid early death, what is now being done is known as the induction chemotherapy, where you give a smaller dose and 1 or 2 drugs only instead of the multi-drug therapy, and stabilize the patient, stabilize the tumor, and then start the multi-agent therapy. That is the induction therapy. So categorizing the risk group into 3, low risk, high risk, and ultra high risk, and accordingly you start the chemotherapy to get a maximum cure. Now the question was there for initially there was no RCTs and other things, but once we started doing the RCTs and other, there was some confusion thrown against, and whether actinomycin is superior to methotrexate. Unfortunately, the earlier studies, some of the studies were showing that actinomycin is, I will not say unfortunately, it is also a good drug, but it was shown that actinomycin is superior to methotrexate, which we were objecting from there onwards because our results were different. But what we could see later on was this comparison was done with a weekly methotrexate, which is only 25 or 30 milligram IM every week. Now it has been shown now that IM weekly methotrexate is inferior to the multi-day methotrexate that we give for the methotrexate folic acid regime. There is a 8-day course, 4 days of methotrexate, 4 days of folic acid, or the daily 0.4 milligram per kilogram body weight of 25-30 milligram daily for 5 days. That's a multi-day therapy. So later on, multi-day therapy was found to be superior to actinomycin D, and now we are sure that it is actinomycin which is to be started first as a single agent. There is no harm in starting actinomycin also. Methotrexate is the superior in the sense that initial response to methotrexate is good, unlike the RCT which was shown with the weekly IM methotrexate. If you do the multi-day therapy, then it is better. So the 8-day therapy that we do, the methotrexate folic acid regime, is which was introduced by Charing Cross Hospital, is found to be effective and with less toxicity. What we give is methotrexate 1 milligram per kilogram body weight intramuscularly on days 1, 3, 5, and 7. With a maximum of 50 milligram. Even if the patient is 80 kilo, don't give 80 milligram because highly toxic. You know, the initial therapy, multi-day therapy was only 0.4 milligram per kilogram body weight. You are even more than 2.5 times. So don't keep on increasing per kilogram weight. A maximum of 50 milligram is advisable. Alternating with the folic acid, 0.1 milligram IM on days 2, 4, 6, and 8. So that's a course of 8-day course. You give a gap of 1 week and again restart. Before starting every course, you have to do the complete blood count, LFT, RFT in these cases, because the count has to be checked. If the count is low or the patient is anemic, the toxicity to methotrexate will be very much aggravated and patient may die because of the toxicity. So you have to be careful about the count and also the liver and renal function test, because methotrexate is detoxified in the liver as well as excreted through the kidney. So if you are having a dysfunctioning liver and kidney, then you are precipitating the toxicity and your treatment may kill the patient, not the cancer. So be careful. We have treated like this and it is very safe regime provided you take the precautions. Even once the beta HCG has become negative, please continue with the 2 to 3 more courses. Now it is recommended to give 3 more courses, because even if the beta HCG is negative, it is required about 100,000 cells to produce 1 unit of HCG. So once it is negative in the lab, doesn't mean all the cells are sterilized. For that knowledge, with that knowledge, we will always recommend 3 courses beyond the normalization of the HCG. So other courses we check 0.4 milligram daily dose is also good. Also, actinomycin can also be given. So it has been proved that multi-day methotrexate is superior to actinomycin D. So as a first single agent, you can choose methotrexate, folic acid or multi-day therapy. And cases which is not responding well, you can switch over to actinomycin D, which is effective and can get 100% cure, but the toxicity may be slightly high. So that's why we prefer the activation folic acid regime, which is known the rescue regime. Rescue means once you are giving the folic acid, the next day after 24 hours or 30 hours of the methotrexate, you are rescuing the normal tissues and the cells. While there is a turf level of methotrexate, which will be acting continuously on the malignant cells. So the normal cells are rescued and the malignant cells will have continued effect even if it is given alternate days. So that is known as the rescue regime, which is found to be effective to get more than 80% cure with that single agent alone in low risk cases. So low risk cases are responding like that. You can choose methotrexate or actinomycin D as per your convenience. Both are good drugs, but the score of 5 and 6, which is a low risk case, are found to have more resistance or relapse with the single agents. So whether we have to think of multi-agent therapy for such group of patients who are having a score of 5 and 6, though they are in the low risk group. Now, we still consider, we have debated this in the last guideline which we have produced. Even though we have identified this group, we recommend that, okay, even if they are in that group with a failure rate or response rate of only 50%, so to say, start with the single agent. If there is a resistance shown, or if there's a evidence of drug resistance, we are immediately changing over to the multi-agent therapy. But at least 50 to 60% of this group, we can achieve a cure with single agent without risking with a lot of toxicity of the multi-agent therapy. So even if they are in that group which is not going to respond well in 100% of cases, still we start with the single agent. 50% at least will respond to that to get a cure, and that 50% is not exposed to the multi-agent therapy with the toxicities. Even if they fail there with the single agent, switching over to multi-agent therapy can ensure 100% remission. So you are not losing anything, at the same time saving at least some of the patient with the toxicity of multi-agent therapy. So that is the 5 and 6 group. Now, drug resistance, you have to keep on watching the HCG every 2 weeks while on treatment. If the fall of HCG is less than 10%, you don't immediately jump on to multi-agent, continue to do with the single agent. And if for 3 cycles it is almost the same way, then don't continue with that single agent. You have to sometime re-evaluate the patient with the metastatic workup. Now you will have chest X-ray, CT chest, and also going for MRI, brain, to see, because she is not responding even though she is in the low risk group. So drug resistance, if you see, probably the patient is having higher risk disease which was missed. So re-evaluate, or the patient has come from outside telling that she is not responding. Again, re-evaluate before, without following with the same regime which was given outside, going to another drug, single agent. Probably she may require multi-agent therapy. So re-evaluate, re-stage, and give the risk score. And if the risk score is more, continue with the multi-agent therapy. If the risk score is low only, you go to the other alternative single agent, still you can get a remission. So that's why we are to always watching the HCG level while on treatment. Every 2 years, you have to see that and see the response. If she is not responding, you may have to re-evaluate. Probably she will require multi-agent therapy. Now, the multi-agent therapy in risk score of 7 to 12 is multi-agent, which is very well established is the Imaco, is etoposide and actinomycin D methotrexate on day 1 and etoposide actinomycin D with the folic acid on second, and after 1 week you increased and cyclophosphamide. So this is a regime which is well established. So the first choice of a multi-agent therapy in high-risk case is Imaco. I don't want to worry with the details of the Imaco therapy. Then ultra high risk, we just mentioned, ultra high risk is 13. What happened to this patient is, once you start chemotherapy with the multi-agent therapy, because of the high risk status, there is early death due to sudden tumor collapse, leading to bleeding, necrosis, metabolic acidosis, septicemia, multi-organ failure, and that's why we don't advise combination therapy, which would have been the choice of treatment for high-risk case. So this group of patients, especially the brain and liver metastasis with a very high score of 13 and above, should be started on a low dose of 2 drugs. What is given is the induction therapy, etoposide 100 mg per meter square and cisplatin 20 mg meter square on days 1 and 2, repeated every week, maybe 2 or 3 courses. By the time the patient, the tumor is stabilized, it is not controlled. Tumor is stabilized, vascularity may be less, and now you start with the multi-agent combination therapy. So in such high-risk cases, probably it is maybe Imaco or maybe better IMA, EP and TTP. So there are so many regimes. You can have so many regimes to get a cure in these high-risk cases also. PSTT and ETT are rare forms of GTN, and they don't produce much of any marker. If you can diagnose before early, confine to the uterus, hysterectomy will be curative with the sampling of the node because it can spread. ETT especially may mimic the cancer of the cervix sometime. So it's all difficult and very rarely seen. Salvage chemotherapy is where you fail, the response is not good. You keep on trying with other group of drugs. Even in high-risk cases, you can go up to 90% cure. So keep on changing. From Imaco, you can go to IMA-EP, to TPT, that is paclitaxel, and so there is so many combination drugs are given to get a cure. And these very desperate cases also, you can get up to 40% cure. Now, other exciting area is the field of immunotherapy in GTN. The cases which are resistant, now it has been seen that immunotherapy is going to give us some result in such situations, like pembrolizumab is being tried in some cases. There's an example of one patient who had Imaco 11 cycles, IMA-EP 5 cycles, like that, plenty of chemotherapy. And this patient was showing resistant to everything. And this patient was started on the immunotherapy, and she became cured after 6 cycles or 16 months after 6 cycles of she was given disease-free. So immunotherapy is coming up. And that is giving us a hope that in respiratory cases, we can think of immunotherapy also to get a cure in this thing. This is just a statistics of early stats of from our institution, which we have done. 1,700 plus vesicular mode, 20% GTN diagnosed. Single agent, that is methotrexate folic acid, given us a cure of 88%. And some of them required hysterectomy along with that, where the response was not good in grand multivirus at that time. So we did hysterectomy also. Nowadays, we don't go into that surgery nowadays usually. Multi-agents were given only to 6% of cases, of which actinomycin following methotrexate folic acid was 10 cases, MAC regime was given 7, and Imaco only for 6. So if you diagnose GTN early following a muscular mode, you can get a cure, and 100% of these patients were cured. And about 100 of them became pregnant later on without any problem. So that is the statistic that we can produce. Just come from Calicut Medical College. Is one of the view of the Calicut Medical College, a huge big complex of 260 acres of land. This is part of it. So I was lucky to be working in this college for 31 years. When I retired at the age of 55, I was very happy to say about Calicut Medical College, and it has given me what I am today. So thank you very much for your patient hearing. If at all there is any clarification, I am ready. Otherwise, carry on.
Jyotsana?
I would request the chairpersons to give their inputs, please.
Hello, everyone. Hello. Ha, you want to say something?
Thank you, dear Komal, for giving me this opportunity to share this session. Actually, Sir has given such an excellent and elaborative talk. And the most important thing about him is he has worked a lot on this. So everything is evidence-based of his own work and not just the bookish coverage. Sir, you have covered everything well. Everything like right related to vesicular mole, then GTN, how to follow these patients, then necessary investigations for this patient, treatment for this patient. Then beautifully, you have covered the FIGO prognostic scoring. The scoring is very beautifully given by you and very understandable to each and everyone. If the score is less than 6, the single drug, between 7 to 12, the multi-agent if necessary, and more than 13, definitely multi-agent therapy if the patient is well tolerating, which you have given. You have advised to start with the methotrexate, and if necessary, the addition of, you have said actinomycin D. And very beautifully, you have given us, guided us regarding the resistance cases also. You said if the patient is not tolerating the multi-drug therapy, how to start with the single drug and how to proceed for the further treatment. So your lecture was very elaborative and very informative, sir. Thank you so much. Thank you.
Sir, yes, sir, I just want to say something. You took me back in 80s when I started in early 80s, my service, I started then. And we have done so many vesicular mole evacuation at that time. And we had only 2 investigations to do. One was the pregnancy test. Even HCG level was not available in early 80. And the second was the tissue biopsy after 6 weeks. We used to call the patient, come back after 6 weeks, and we used to do the DNC and send the tissue biopsy. That was the only thing we had. But sir, you made it so simple now with the technology. I know, I regard them. They had brought technology to our life in our medical science, like ultrasound. Now you put the probe of the ultrasound and you can see the findings over there. And at that time, we had only an X-ray, and we used to do X-ray chest to see whether secondaries has reached in lungs or not. This was our view at that time. But sir, this was such a beautiful lecture, and you have covered each and everything. The thing is,
each and every
yes,
topic.
the thing is really management simplified. So I agree with you, sir. And sir, thank you so much for giving us such a good initiative. I came to know about folic acid very late. We used to use only one drug, methotrexate. We were not using the folic acid, but now we are following that regime, which you have said. And Komal, I just want to thank you, and I want to give you all my wishes from Uttarakhand, Devbhumi Uttarakhand, and you have all the success in your life, and we are waiting for the coming success in your life.
Thank you, thank you, thank you so much.
Thank you very much. And all the best, dear Komal, for your
Yes.
forthcoming elections.
Thank you, Dr. Jyotsana and Dr. Sarveshwari, madam. I think you have done a fabulous job chairing this session. And if I think about gestational trophoblastic neoplasm in India, the only name which comes to my mind, and I think everybody, is Dr. P K Shekharan. And he has done numerous studies. I have been knowing Sir since long time, and we have been reading references about Sir in this subject. And when he speaks, we know that it is his personal experience which is going to speak, and that is more important than the books. Thank you, sir, for coming here and sharing the knowledge with all of us. I'm really honored with your presence.
Thank you so much, Dr. Sekharan. It was such a good subject, and really you have told us those regimes we can help our patient a lot. Thank you so much.
Thank you, thank you, sir.
Thank you. Thank you very much.
Thank you, Dr. Shekharan. With this, we would start the third session, a very interesting panel discussion. And the panel discussion will be on the gestational diabetes and the antenatal and intrapartum management. I would like to invite Dr. Manoj Chellani, sir, is the moderator for this wonderful panel discussion. He's a director at the Ayush Hospital and Test Tube Baby Center, Raipur. He's a chairperson of the Medical Disorders in Pregnancy Committee of FOXI, a past president of the Raipur OBGY Society. He's a chairperson-elect of Chhattisgarh ISAR 2023 to 2025, chairperson of the Urogynecology Committee of the Indian Menopause Society, a vice president of Chhattisgarh ISOPAP, vice president of IMA, and he has been awarded by the Chief Minister of Chhattisgarh. Welcome, sir. I would also like to introduce our expert on this panel, Dr. Komal Chavan. She's a medical director of the Chavan Maternity and Nursing Home, a senior consultant, DNB teacher, and a unit chief at the VND Desai Hospital, Mumbai. And she is in the past worked at the Cooper Hospital also. And she has been a chairperson of the FOXI Medical Disorders Committee in the pregnancy, a zonal coordinator for FOXI, and she has a number of awards at her she has been awarded the Pandit and Mrs. Shailaja Pandit Women Empowerment Award in 2022, the FOXI Dhira Award 2022, and even she has been a recipient of Dr. Mehru Hansotia Best Committee Prize in 2021, a Nari Shakti Samman Award by ISOPAP in UP Chapter 2021, and Wonder FOXI Award. Welcome, Dr. Komal. And I would now request Dr. Manoj Chellani to introduce our esteemed panelists for this wonderful discussion.
Before Dr. Chellani starts, I would like to say that after being the chairperson of medical disorders, I have handed over to the much able person, Dr. Manoj Chellani, and he is a real dynamic person, and I'm so happy that the work he is doing for the committee. Today, we were blessed with 3 chairpersons of medical disorders in pregnancy committee, Dr. Girija Wagh, who is the VP Vice President-elect, and I'm the past chair, and Dr. Manoj Chellani. So yeah, it's a real great moment for us. Over to you, Dr. Chellani. Audio.
So you're muted. It's not audible.
Echo ahead, Dr. Chellani.
Yeah, I think I'm not audible from this thing.
Okay, fine.
Okay. So thank you, Dr. Komal ma'am, for giving me this opportunity. And it was really great to have the two past chairpersons of medical disorders in pregnancy committee FOXY, and one is vice president now, and another one I would like to say that vice president elect. So I would like to introduce Komal Chavan madam as a vice president elect, just a few months away to be. So all the best, Dr. Komal ma'am. And it will be really a pleasure to see the two chairpersons holding this post of vice president one after another. So we are already late, so I'll start this thing. So can someone, yeah. So I would like to introduce a very great person, Dr. Chitra ma'am. She's a very renowned and very good academician. She's the professor and unit chief of OBGYN Society of PSD Institute of Medical Sciences, Coimbatore. And she's the president of COVI and ONG Society. And she's a member of IUG and ICUOG. And she's got special interest in urogynecology, high-risk pregnancy. She's a postgraduate teacher examiner from 1998. And she has been a faculty in the Institutional Medical Education Technology Cell, organizing secretary for many department conferences, CMEs, PSG, IMSR. And she's got many publications, national and internationals, to her credit. So welcome, Dr. Chitra ma'am. It will be great to have you as a panelist. Dr. Shahnaz Taing, and she's the head of the department at Lal Deg Hospital at Srinagar. And she's the president of Srinagar OBGYN Society, was awarded for her contribution to the field at North India Fertility Conclave in Delhi. She's working for the advancement of fertility treatment and advocating for giving a flip to infrastructure and human resources at the hospital and across Kashmir to help serve women of Kashmir better. So it's really a pleasure to have you, ma'am. Welcome. Dr. Anshu Jindal, ma'am, a great friend of ours. And it's really a pleasure to have you, ma'am, here. She's a joint treasurer of UPSA. She's editor of UPIG, member of Infertility Committee FOXY, gold medalist for best postgraduate LHMC New Delhi. And she has got more than 30 awards from different organizations. She has been trained in laparoscopy, infertility, runs of FOXY recognized centers, and has published many chapters on fertility and delivered more than 6,500 babies through ART techniques. So welcome, ma'am. It is really a pleasure to have on board.
Thank you so much.
Now, Dr. Archana Kumari, she is the secretary of ISOPA, Ranchi chapter, founder secretary of IFS, Jharkhand chapter, East Zone coordinator, quiz committee of FOXY 2018 to 23, FOXY representative of ROGS 20 to 23, vice president, Ranchi OBGYN Society, secretary, Ranchi OBGYN Society, organizing secretary of FOXY East Zone Conference with UVA, organizing secretary of 8th annual conference of ROGS, and organizing secretary of midterm annual conference. So welcome, Dr. Archana, and Rashmi Kahar. She is senior consultant and current chairperson of the high-risk pregnancy of committee of MOGS, and known for expertise in high-risk case in obstetrics. So it will be really great to have you here. We have Professor Mandira Dasgupta, and she is from Purulia, West Bengal. She's professor head Department of OBGYN, Deben Mahata Government Medical College. She is faculty in the National Program for Prevention, Control and Management of RTI and STI by syndromic approach, and she has a lot of publications to her credit. So welcome, Dr. Mandira ma'am. Now we have Kirtan Vyas. He is consultant gynecologist at Sevak Maternity and Surgical Hospital, Ahmedabad. Studied MS at NHL Medical College, Gujarat University, Ahmedabad. Welcome, Dr. Kirtan. So we have a galaxy of panelists and very expert in their own field. So can someone, yeah, please share the screen, or I'll share it. Okay. Yeah. So we are very short of time. So I'll go through rapidly. And without further ado, let's start with Dr. Anshu Jindal, ma'am. Now, why is pregnancy diabetogenic?
Yeah, absolutely. Pregnancy is a diabetogenic state because the mother has to supply constant source of glucose to the baby. And that is why by default, the blood sugar levels are slightly higher in pregnancy because the blood sugar, there are certain insulin antagonist hormones which are secreted by the placenta, and like the human placental lactogen, HPL, cortisol levels, estrogen, progestogens, and some hormones which are secreted by the kidneys and the liver also, which are actually insulin antagonist. And moreover, because of this, there is a slightly higher fasting, slightly higher sugar levels in the mother. And it has also been seen that it is not only the carbohydrate metabolism which is affected, it is also the fat metabolism which is affected, because the fat storage which happens in the second trimester, actually in the form of lipolysis, in the third trimester, this fat is broken down into free fatty acids for utilization by the mother, and hence it becomes a diabetogenic state, which means the sugar levels rise higher in pregnancy because of the inherent insulin resistance which happens in nature.
So well replied, Dr. Anshu ma'am. So now let's start with the case. There's a 34-year-old lady who is married since 4 years, who is in her first pregnancy with IVF, is seen for the first antenatal checkup at 10 weeks. Her family history reveals that her mother has type 2 diabetes mellitus. So we discuss what are the risk factors for her. For GDM, is screening required? And if yes, whether we should go for universal or selective, and how you'll perform the screening, what is one-step screening procedure introduced in India, and how you will diagnose GDM, and other tests of screening which are recommended. So we'll start with Dr. Shahnaz. Dr. Shahnaz, what are the risk factors for GDM? Which patient you'll consider like you'll be apprehensive that they may have GDM? So can you just throw a light on this?
Actually, sir, I think Dr. Shahnaz has not joined. She has mentioned her apologies in the group, I think.
Yeah, someone else can pick up this.
Yeah, so risk factors. Yes, sir. Risk factors for diabetes is like increased age more than 35, increased parity, increased BMI, increased like family history of diabetes and first degree relative. And if we take history, past obstetric history, the history of stillbirth, macrosomic baby, unexplained stillbirth, and of course, history of congenital malformation. If you take history of the present pregnancy, history of recurrent UTI, if there is polyhydramnios, and all these things, I think are the risk factor for GDM.
Yeah. So very well said. Age is very important. There's a high age is there, parity is there, high BMI. If the patient is PCO, then more chances of this thing.
Yes, PCO is also.
Then you have to take the family history of the mother, whether maternal, someone in the family has a GDM, her mother has a GDM, and what are the diets also. So these things are very, very important in history. So Dr. Rashmi, is screening required for any of your patient, and which type of screening you'll offer to your patient, and how you'll perform the screening?
She's not seen, I think.
She's also not there.
I'd join actually.
Dr. Chitra can answer. Dr. Chitra, you are there?
Yeah. Now, for this particular person, screening is definitely necessary. And because she is an Indian, technically she becomes at a high risk group. So the screening that we should offer is universal screening for this particular person. And now she's 10 weeks. So at that 10 weeks itself, we would offer her doing a GCT with a DIPSI method, 75 grams of glucose. And then you do the blood sugar after 2 hours and see what is the report. If the report is less than 140, you will say it's, above 140, you will say it's GDM. But if it is less than that, between 120 to 140, you will say it's a GTI. And if it's less than 120, you will say it's a normal test.
So ma'am, what is your suggestion? Will you go for a universal screening, or you like to have a selective
100% you will do a universal screening for this person because she's from India, and India, ethically we come under high risk group. So we will definitely screen all patients. That is what the GOI of Government of India also suggests, universal screening rather than selective screening.
That's correct, madam. And sir, yes, this DIPSI has probably revolutionized the screening methods. It's very comfortable, very convenient and easy to perform, as well as patient
We'll come to
compliance.
that. Yeah,
Patient compliance is very good.
Definitely, we'll come to that. So
Yes, sir.
there was the other view that one should do selective screening because to save the resources and this thing, it may be expensive. But I think looking at the consequences of diabetes, universal screening should be done. So
and because moreover, the incidence of patients with the GDM and diabetes is really increasing. Roughly around 15 to 20% of all patients come to OPD seem to be suffering from either GDM or 5 to 6% also have diabetes. So it's important that we screen all individuals.
Right. So ma'am, we have already discussed about the risk group, but still, can you throw some light on what are the risk groups?
See, normally we will divide them into low risk individuals and high risk individuals. Low risk individuals are generally those people who come from an ethnic group who are not, who are risk group, and less than 25 years, if the BMI is less. These all, they don't have any family history. These individuals become low risk. High risk people will be obese patients, elderly individuals, and those having a family history, obstetric history, previous performance, if they had congenital anomalies, etc. If the obstetric performance were poor, or during the current pregnancy, like how the previous speaker already told us, if the current pregnancy, if she has any risk factor like hydramnios or a baby with congenital anomalies, they become the high risk group.
Or even if the weight gain is too much in this pregnancy, or then also you have to be alerted, because sometimes you see an ultrasound that the growth is more than what is expected at gestation, large for dates.
Yes,
so
correct.
then there also you get alerted, and as an IVF specialist, I would say that IVF pregnancies are also are considered high risk and should be screened as soon as possible.
Right. So in present pregnancy, we should look for recurrent infections. If there's a polyhydramnios or these are the things which they are the high risk. So Dr. Kirtan, at what period of gestation these tests should be done?
So the simple answer should be as soon as possible. When the patient comes to you for the first ever examination, yes, of course, at the time of first screening, the universal screening, the DIPSI, as Madam has rightly mentioned, that should be done, because sooner is better. Many a times what happens is that if the screening test is done at a later gestational age, then the chances of picking up the early patients, the patients with rather over diabetes mellitus, or the patients who are not aware of their diabetic status, may be missed. So yes, of course, in the first trimester itself, the DIPSI test should be performed.
Right. So as soon as your patient comes to you on a first visit, the test should be done. And even if she comes at 28 weeks, you should rightfully do the test.
Yes, correct. As you rightly mentioned, sir, even when the first screening is negative, then also the test should be repeated in second trimester, or rather late second trimester of the pregnancy.
24 to 26 weeks.
Yes, correct.
Dr. Archana, what are the criteria for GDM? What criteria you would follow?
Actually, there are different criteria for diagnosing GDM, which includes National Diabetes Data Group, American Diabetes Association Group, then Carpenter-Costin criteria and WHO criteria are there. And most of them rely on 100-gram oral GTT. They take 4 samples fasting, 1 hour, 2 hour, 3 hour. National Diabetes Data Group has slightly high cutoff level for like for fasting, it is 105, for 1 hour, it is 190, 2 hour, 165, and 3 hour, 145. Whereas American Diabetes Association and Carpenter criteria, they have similar cutoff, and this is lower than the National Diabetes Data Group cutoff. Like it is, fasting is 95, 1 hour is 180, and 2 hour is 155, and 3 hour is 140. Whereas WHO criteria relies on 2 hour oral GCT, which is 140 milligram cutoff, and fasting is 126. And so for criteria other than WHO, actually 2 or more values have to be abnormal. For WHO, only 1 or more criteria makes the test positive. Well, we are following the one-step 75 gram 2 hour oral GCT.
Yes, we'll come to that. We'll come to that. Dr. Mandira, what is single-step test, and how would you like to do? Dr. Sachet has advocated this test. So can you explain the procedure for this one-step test?
Yes, now this single-step test is now being used for screening and diagnosis of this GDM patients. and it is a very easy method. What we do is we give the patient 75 grams of oral glucose dissolved in 300 ml of water and ask them to take it within 10 to 15 minutes time. And this is done without any regard to the last meal. So fasting is also not required. And 2 hours later, the plasma glucose is measured. And if it is more than the cutoff, that is more than 140 milligrams per deciliter, then we consider that patient to be GDM. And if it is more than 200 milligrams per deciliter, then we consider that patient to be a frankly diabetic patient. And this is a very good method. And one thing is sometimes a patient might vomit because of taking so much of glucose at a time. So if the vomiting is within 30 minutes, then we have to again give her the same drink and do the test. But if she vomits after 30 minutes, or what we can do is we can abandon the test on that day and repeat it on the next day. And if the patient vomits after 30 minutes, then we can continue with the test.
Good. So
and
that's the
one more
advantage.
thing is,
yeah. So advantages like
so it avoids the
patient
multiple
doesn't have
visits
to
and
be-
multiple samples. Yeah.
Yeah. So patient don't have to be empty stomach. She comes in the morning and the test is okay. Dr. Komal, ma'am, your views till now, like what we have discussed.
Yes.
Dr. Komal.
I think DIPSI test has revolutionized the screening of diabetes because we really need something which is fast in India. Seeing the workload when the patient come and explaining to them at every visit the importance of test. I think now even the Pradhan Mantri Surakshit Yojana, which they have in all the government hospitals, they are also tying up with laboratories. They're at least doing an OGTT. So diabetes is something which is a universal screening is happening in India. There are high-risk screening programs which are screening these high-risk mothers. So this is everywhere. And DIPSI test is the most convenient test. Only thing is the availability of the sachets. You know, at times they are not available at public hospitals. That is a concern for many.
Yeah, actually, ma'am, that is a concern in government hospital, actually.
Yes.
And sometimes the patient take that Glucon-D but that is something different. The sachet has to be anhydrous glucose has to be there.
Anhydrous. So that is very important. So that is only the concern. The rest in private places, we really have a 75 gram glucose. So giving it becomes very easy. And it is given at the single point when the patient enters. And we really can diagnose diabetes very perfectly. You know, we can screen the patient normal to glucose intolerant, to gestational diabetes, to diabetes. You know, the cutoff is very clear about that. We need to take the levels after 2 hours and see if they are above 120 or 120 to 140 or 140 to 200. So 140 to 200 will be your GDM, but above 200, then probably the patient may be having a diabetes. So we can diagnose a pre-existing diabetes and then we can resort to HbA1c if required. So this test will give us a very comprehensive status of the patient at any gestational age. And even if it is normal, I think the point which was taken was very valid, that you need to repeat it. You need to repeat at 24 to 26 weeks, and I'm repeating for all my patients. And there are so many patients who are having late onset gestational diabetes also. So those patients really help because then you have to make a decision for delivery or any unforeseen consequences later on.
Right. Thank you, ma'am. Well summarized. So, Dr. Anshu, ma'am, what are the other tests which can be used for screening apart from the single test?
I think the other test which all of us use in our practice, which I also use very often, is the HbA1c, which is the glycosylated hemoglobin, which gives us a very good idea of glucose control in the last 3 months. And if it is, that is also another test. And we are doing the standard OGTT after 100 grams of glucose, where we are taking 4 readings, the fasting, 1 hour, 2 hours, and 3 hours. And as reiterated, that if any of the readings is abnormal, then you have to be, you have to be more alert and you have to give them the required treatment. So basically, you are using HbA1c along with this OGTT after either 75 grams of glucose or after 100 grams, depends on place to place.
So, ma'am, are you doing that glycosylated fructosamine test? How common it is being done?
I'm not doing it. I'm not doing it.
So Dr. Shahnaz is not here. So I'll ask Dr. Chitra, ma'am, what are the complications of gestational diabetes?
Gestational diabetes, the most important is on the fetus. The one thing which comes to our mind is macrosomia and problems associated with macrosomia. GDM is different from diabetes. So if it's a GDM, it's mostly the fetus which is being affected. There is macrosomia of the baby. Then because of macrosomia, there will be other problems like shoulder dystocia, etc. More chance for cesarean section. As far as the mother is concerned, there are more chances for urinary tract infections, polyhydramnias. That will tell us that the sugar level is not under control. So polyhydramnias is one thing that we should look for. That will tell us is the GDM under control or not. And a little more chance for abortions. And of course, preeclampsia.
Right. So there are neonatal, there can be neonatal hypoglycemia, neonatal hypomagnesemia may be there, neonatal polycythemia may be there.
What I think we are afraid of in a diabetic mother is IUDs which happen at around 35 weeks, 36 weeks. That is what, obstetrician, as an obstetrician, we are all afraid of, because diabetic control is very important. Otherwise, there are unexplained IUDs because of all the, carbohydrate metabolism which is going haywire, and uncontrolled diabetes can have IUDs and stillbirths. That's very scary.
True,
so it's more common in the case of diabetes. It's more common in the case of diabetes, whereas GDM patients are unlikely to have IUDs. If the sugar is under control, like I'm sure Dr. Manoj will be telling us how we should monitor the sugars. The sugars are well under control. In the case of GDM, it's unlikely that they will have congenital anomalies. It's more common with diabetes per se, complicating pregnancy.
Right. So we have to be really very careful about the anomalies also. Proper anomaly scan should be done and all. So Dr. Rashmi, there's this 29-year-old lady weighing 70 kgs, G4P12, presented with single live fetus of 27 weeks. On her ANC evaluation, her glucose tolerance was found to be deranged. So what history is important in this case, Dr. Rashmi? Dr. Rashmi, what history is important in this case?
A previous obstetric history is important because we do not know anything about the previous pregnancy as such. What was the weight of the baby? Was it normal delivery, etc. And did she have GDM?
And also in the history of 2 previous abortions. Was it due to GDM? Or it could be overt diabetes? So history of
right.
Yeah.
So we have to really evaluate her, know her family history. If someone in her family has diabetes, about her mother, and things like that, and that we have to really find out.
And what was the sugar in the first visit? Was this the first time that she's been having a sugar, or was she detected to be having hyperglycemia earlier on in pregnancy? That will tell us how it was.
Yeah. So Chitra ma'am, she has come to you now. What test you will advise her and how you'll go about it? Now,
when I look at the results, all the results are, all the 3 values are high. Fasting blood sugar is high, the first 1 hour level is also high, and the second level also is high. So it fits into the criteria that she must be having a GDM. So now she's already 27 weeks. So because she's already 27 weeks, I would like to screen and see whether this particular person has more chance of developing preeclampsia. So as a routine, I would like to see her urea, creatinine, etc. And because we're just seeing her for the first time, it is important to rule out an overt diabetes also because the levels are deranged. So HbA1c might to a certain extent help us to find out whether she was a case of overt diabetes. So HbA1c might be useful in this particular case. Apart from it, as a routine, apart from the routine investigations, do a renal function test and a thyroid function test.
Dr. Komal, your views on this? The patient has come for the first visit with a past history. So how you would like to investigate this case?
Yes, so she has definitely a strong positive past history and she becomes in the high risk category. And this patient requires a proper screening at the first visit itself. And here we can actually do a DIPSI test, but HbA1c will be more accurate to know her pre-pregnancy sugar level, whether it was under control or no, because sometimes these patients are not taking the medications properly, and that causes fluctuation of the sugar levels. So doing her HbA1c, doing her complete investigation panel, doing her other endocrine profile, her hemoglobin, everything, the whole investigation as early as possible will be helping. And these are the patients in first trimester, they require an early first trimester level 1 ultrasound, that screening ultrasound. These patients, you should tell them, you can get a uterine artery Doppler done to know if she is high risk for getting the mean arterial pressure, high risk for preeclampsia also, because that is the history of this patient. So the approach should be that way. And then if her sugars levels are high, if she is taking any treatment, then whether it is an insulin or an oral hypoglycemic agent, metformin can be continued. That is the best thing. So she needs to continue, and then the levels needs to be monitored also subsequently, whether there is a good control or pregnancy is causing fluctuation in her sugar levels.
Right. So proper
Actually, she
history
has
about
already
her past
crossed the
pregnancy is very
anomaly scan
important, and then
gestational
detailed
period.
examination.
So was fetal echo done or not at 24 weeks? He's already 27 weeks now.
This patient is already 27 weeks.
Right. So Dr. Vyas, how would you like to counsel the patient? How many visits you will advise her? When she should visit any ANC patient? How many
Yes,
visits?
of course, we need to follow the routine antenatal protocol as all the investigations are done. Ideally, the visits should be little earlier than the standard patient, rather every 20 days up to the 7th month, that is 28 to 30 weeks. Then every 15 days, 10 to 15 days, I would ask her to visit me. And in the later part of the pregnancy, in third trimester, of course, the weekly visits. And these patients are the group of patients which needs to be strictly monitored by your hospital staff even. And in case of any emergency, like a decrease in fetal movements or any other complications like bleeding or something, they should be immediately calling up the hospital and should reach the hospital at the earliest. That would be my protocol in such patients.
How you like to examine her, and what
Of course, all the routine antenatal checkup parts like the assessment of fundal height and the fetal heart rate monitoring during every antenatal visit. Her blood pressure should be monitored very judiciously, considering the risk of preeclampsia, and also the timely sonographies like the first trimester knuckle scan and the screening test, as well as the second trimester targeted anomaly scan, which also includes fetal echocardiography, and the third trimester Doppler. This all should be going as per the protocol.
Right. So, Dr. Archana, what are the indications for termination? Till where you would like to continue the pregnancy?
To delivery, I want to add that these patients, sometimes if they have long-standing diabetes, you get a retinal examination, the fundoscopy also done, because that also is a part of the workup for diabetes, a routine fundoscopy, because we don't want any complications later on when the patient comes in an advanced stage. So send her to your ophthalmologist, check her fundus exam.
Right.
For diabetic retinopathy, yes.
That's true. So, Dr. Archana, what are the indications for termination? Where you would like to terminate this
Actually,
pregnancy?
all cases of pre-gestational diabetes or diabetes mellitus, they should have a pre-conceptional care during which they should have a fundoscopic examination, renal assessment, and glycosylated hemoglobin assessment, and only they should have a strict glycemic control. Only when they become euglycemic, they should go for conception. But many a times we do see cases coming to us in the first trimester with elevated glycosylated hemoglobin level, maybe more than 10%. And then the risk of congenital anomaly is as high as maybe 22 to 25%. So then we might have to counsel the patient for termination of pregnancy. And of course, if she is having a proliferative retinopathy or severe diabetic nephropathy, then we may have to counsel her for termination of pregnancy.
Okay. So Komal ma'am rightly said that fundus examination should be done, and we have to check HbA1c levels, and when there's severe nephropathy, then termination should be advised.
And termination of pregnancy in the second trimester, if a congenital anomaly has been diagnosed, which is over diabetic, and it's diagnosed by time, then you have to, there can be grounds for termination there also.
Right.
Can I just make a comment?
Yeah.
No, because if it's HbA1c is elevated more than 10, that only means that there are more chances for developing a baby with a congenital anomaly. So it's important that we explain the risk to the patient, and it's left up to them whether they would like to continue the pregnancy or not.
It depends upon
So
the
just,
patient's wishes.
yeah, so there's it
But
doesn't
still
not
with that
certify an indication for
glycosylated
termination.
hemoglobin, still there are 75% chances that she will have a
So
normal baby.
we have to tell them the risk, and many, because if you have a very good sonologist, they can pick up anomalies. So it's important to counsel them and let them take the call whether they want to continue or not continue.
So, Dr. Mandira, there was this patient, 33-year-old, diagnosed with diabetes in the present pregnancy. The routine glucose challenge test performed at 28 weeks was elevated at 208 milligram per deciliter. Her HbA1c was elevated at 7.6. And the fundus examination was normal. There were no changes. So I would like to know, explain how, like, what will be her nutritional therapy? How you will, what nutrition you will advise her?
Yes, the backbone of treating a diabetic patient is providing or advising regarding a proper diet and exercise. So medical nutrition therapy is very important part of the initial management protocol of a GDM patient. We should have a very good, we should tell them that they should consume the carbohydrates, proteins and fats. These should be in the proper ratio. And we should tell them in what ratio they should be. For example, the carbohydrate should be around 50%, the protein should be around 25%, and fat should be around 30% of our calorie intake. And like shown in this diagram also, we can also calculate the calories required based on the BMI of the patient and add extra calories for the developing fetus. The ICMR has also provided guidelines for that. And majority of the patients with GDM, they will require around 2,000 to 2,500 kilocalories per day. And her meals should be planned in a fashion. It is better to divide the meals into small parts rather than to give them large, big meals at a time. And it is better to divide it into 2 parts. And lunch, dinner, and we should have in between snacks, preferably at 3 to 4 hour intervals. Now, the carbohydrate portion should be divided as a breakfast. We should give her 10% of a carbohydrate requirement. In the lunch, dinner, and snacks portion, around 30% of that should be.
Dr. Komal ma'am, you know that diet plays a very, very important role in diabetic patients. So how you would like to counsel a patient as far as diet is concerned? Because that's the first thing we would like to counsel her, exercise and diet. These 2 things play a very, very important role.
Yes, see, whenever a patient...
Yes. So our carbohydrate... Yeah, Komal ma'am.
Yeah.
Continue.
So what has happened is that now we have even the GOI guidelines also say that medical nutritional therapy becomes the first line of therapy which we need to tell our patients when they are diagnosed with diabetes. And that medical nutritional therapy is nothing but a diet with low carbohydrate and increased amount of proteins. And when the diet is given in such form, it will actually have all the nutrients. We should balance and give a diet plan which has an optimum calories and everything, so that along with exercise, so that the weight of the patient is controlled. And then when we tell the diet, I think they have explained very well how to take the breakfast, the diet plan. If the patient is not following, a nutritionist needs to be roped in. And you can tell them to have simple meals, small portions of meal, cut down on complex carbohydrates, which are really not very healthy, and increase the protein and fiber content of the diet. That needs to be told all the patient. And when they are on medical nutritional therapy, you can safely make them on therapy for the 15 days, for the next 15 days. And if the blood sugar level comes to normal, it is very good. But if it is not coming to the normal, and if you feel it is above 120, then you need to see if the patient is 20 weeks, below 20 weeks or above 20 weeks. If the patient is below 20 weeks, then we need to consider starting insulin therapy because she's not responded to medical nutrition therapy and she is definitely a diabetic and she will require insulin because she is less than 20 weeks. But if she is about 20 weeks and the blood sugar levels are high, then we can start her on oral hypoglycemic agent like metformin starting at 500 twice a day, we can start. And then we can even increase to maximum 2 grams. So metformin can be safely started. And metformin is a drug also when we are suspecting any macrosomia or anything, it really works very well. So the medical nutritional therapy acts as a cornerstone of the management. And on basis of that, you can start the drug therapy later on subsequently.
Right. Well said. So Anshu ma'am, how you'll explain her the home monitoring of glucose? How you'll tell her to monitor the glucose at home?
Yeah, so she has to buy that machine where she has to do the glucose monitoring herself. You have to explain the steps for the glucose monitoring, and she has to do it at least 4 times a day in the beginning at least. And I would reiterate that, you have to involve a physician or a diabetologist in this whole, workup, because you need to know insulin, what doses. So we always involve a diabetologist in this whole management. And as you can see on the screen, the fasting level should be less than 95. The 1 hour should be 1 hour post meal. So she has to do 4 tests fasting and 3 blood tests post breakfast, post lunch, and post dinner. And the post meals, if done 1 hour, they should be less than 140. If done after 2 hours, it should be less than 120 milligram per deciliter. And normally it's easier to control in GDMs, but in type 1 diabetes, I think it requires more regular monitoring because they are more difficult.
Yeah. So she should maintain the diary. She should know the values before eating, 2 hours after breakfast, then 2 hours after lunch to after dinner, and what amount of insulin she is taking. So that is very, very important. Now, Dr. Chitra ma'am, diet we have taken care of. Now we want to give her advice regarding the exercise. So what kind of exercise you will advise her, how much exercise she can do? And
see, for these diabetic patients, one thing is after every meal, you ask them to walk for at least half an hour. Because this postprandial hyperglycemia will be reduced by walking after half an hour, following food. So after every meal, that is one thing that you say. So at least minimum of brisk walking around 120 minutes.
140 minutes per week.
120 minutes or 20-30 minutes every day. So that roughly around 120 minutes in a week. So that should be advised. And if she wants, she can either do very, not very brisk exercises, but at least walking would be the best. Little bit of aerobic exercises she could do. Some people come and ask us, can we go swimming and all those things? If it's not contraindicated, they should definitely, we could encourage them. It's not a contraindication. But walking is the easiest.
Chitra ma'am, we have advised regarding diet, regarding exercise, but still we are not getting results. So we want to start with oral hypoglycemic agents. So can you throw some light on the oral
the first thing,
anti-diabetic
like
drugs?
you said, if you diagnose hyperglycemia, the first step is MNT and exercises. So you continue that for 2 weeks. If in spite of 2 weeks her blood sugar levels are high, she comes back, we ask her to do a fasting blood sugar and a PPBS. If the fasting blood sugar is more than 90 or the PPBS is more than 120, that means the sugar is not controlled with these 2 things. Then that is the time when you can start her on oral hypoglycemic drugs. What we follow in institutions to start them on metformin, depending upon the blood sugar levels, we could go up to 500 milligrams BD or TDS. We could go up to 2 grams. You continue the same thing and you ask her to do the self-monitoring with blood sugar at home and come back, what her levels are. If the level is controlled with this, you continue the same thing. If the level is not controlled, when she comes with after 2 weeks, then that might be the time when you might require to switch over to insulin. So we normally use metformin. We don't have much, though glyburide can be used, we have not had much experience with glyburide.
Right. So can you also tell something about the insulin therapy, Dr. Chitra?
Yeah.
How much dose and how you'll start?
Okay, so there are different types of insulin that you can have. We can have regular insulin. We can have mixed start insulin. We can have ultra short insulin, that's insulin analogs, and we have basal insulin. So when will you start insulin? So when the sugar is not getting controlled with the MNT, that might be one indication. Or MNT and then oral hypoglycemic drugs, if the sugar is not getting controlled, that might be the second indication. Or in some cases, if the fasting blood sugar is very high in the first trimester, that might be an indication for starting insulin. Now, what insulin are we going to give? What the government of India says is, you give, for it to be very easy, you can give, mixed-start insulin. You identify what is the dose that is required for the patient, and you give the mixed-start 2/3 in the morning and 1/3 in the evening. That is one way in which you can give. But if you're in a corporate hospital where you have facilities and the patient can afford, then that might be the conditions where you could give regular insulin. After every meal, you could give pre-breakfast, pre-lunch, and pre-dinner, you could give a regular insulin. And in addition, if necessary, you could add a mixed-start insulin can be given accordingly. Sometimes they give a basal insulin, like we have the long-acting insulin, which works for 24 hours. And in addition to this basal insulin, you could add the short-acting. So when you're starting insulin, generally, if it's a very small dose, we might be able to do the same thing. But if patient requires high doses and if the sugar levels go haywire, it is better that you consult, that you involve an endocrinologist will be able to modify the doses. And very, very important that you tell the patient to do self-monitoring. So all the four values in a day must be seen so that we will be able to adjust the dose according to what is necessary. If for pre-fasting is high, then maybe you should increase the night dose. If her PPPS is high, you might be able to increase the dose, which is just before that. So that is the way you should do. So you have various incidents.
Komal ma'am, would you like to sum up that this part? Treatment, oral as well as insulin. Anything else you would like to add?
I think everybody has very beautifully pointed out the oral therapy. We know that nowadays everybody is giving metformin in the practice, and we are seeing very good results. And it is not necessary now directly to start over the insulin therapy, which was happening earlier. So metformin is really very there. But when there is no control of metformin, or you feel the sugars are very high, or there is a very high HbA1c level in spite of whatever treatment she's taking, these are the patients which require insulin, or if a patient is having some consistent vomiting, or the patient compliance is not there. So insulin becomes a safer option for control of sugars. And Dr. Chitra has very well said how the insulin needs to be divided and taken, and the monitoring is most important. When we are giving insulin, we don't want reverse phenomena of early morning hypoglycemia or the dawns or the somagai effect, which we see it. So this is very important when we give insulin. So monitoring becomes very, very important, and monitoring that we don't have a very high or even the low sugar. And for that, there are combinations of insulin, how we divide the doses and give the major part in the morning, that is a 2/3, and 1/3 in the night. And out of which can be the long acting and short acting, the combination, something which is going to work better if you require, patient requires a long-term insulin therapy.
Right. So, Dr. Vyas, can you tell what is Somogy's and Down phenomena?
Yes, both are mostly found in patients with rather over diabetes, or the patients in whom the gestational diabetes is not controlled. Hyperglycemia is common. The fasting hyperglycemia is common in both the patients. But the difference is that Somogy phenomenon patients, they have rather an overdose of insulin at bedtime. So what happens is that during midnight, they have an episode of hypoglycemia followed by fasting hyperglycemia, considering the rebound effect of the hormones. While in patients with a Down phenomenon, in those patients, the dose of insulin at bedtime is insufficient. So that leads to fasting hyperglycemia. So if we wish to demarcate between both these phenomena, we need to have a glucose check, a sugar level check at midnight, at rather 2 a.m. or 3 a.m. The patients with Somagai phenomenon, they have an episode of hypoglycemia at midnight, while the other kind of patients won't have such kind of hypoglycemia.
Right. So we are really short of time, so we'll just try to finish as much as possible. Dr. Archana, but tell us the timing and mode of delivery for those patients.
Actually, if it is a well-controlled diabetes, especially with exercise and diet, we can take it up to 40 weeks. But if not well-controlled and especially she's on insulin, maybe we try for earlier delivery by 38 weeks. If she has complications like preeclampsia, maybe even earlier than that, about 37 weeks or something like that. That is how we decide. But we never go beyond 40 weeks, even in well-controlled diabetes.
So Anshu ma'am, we would like to know how you would like to manage the intrapartum insulin.
Yeah. So this insulin therapy during labor Intrapartum insulin management, it's done by first doing the fasting blood sugar level of the patient. And depending on that, if the fasting blood sugar levels are low, sometimes these patients can have fasting hypoglycemia. You might have to start them on a dextrose strip. Otherwise, if the levels are between 70 and 120, then you can you will do a blood sugar level and start with insulin infusion at the rate of 1 unit per ml by dissolving 50 units of insulin added to 50 ml normal saline, and you will monitor the blood sugar levels, and the blood sugar monitoring will decide how much of insulin. Usually it's given at the rate of 1 ml per hour.
Yeah. So like, should the patient be fasting in the morning? What you'll advise her?
For a patient in laboring patient?
Yeah. We are talking about the patient in labor.
Yeah. So if no patient, if she's in labor, she can have a meal, and we'll just do her blood sugar levels, fasting blood sugar level. She can have a meal, and then labor induction can be started. So she need not be fasting. So actually it's the blood sugar monitoring which will decide how much of insulin she requires through the day, because labor is going to be long for at least 12 hours or even 16 hours. So you have to monitor the blood sugar and decide the insulin level. And normally we involve a diabetologist here. So in conjunction with the diabetologist, we decide the dose of insulin and give the doses as required. Usually in labor, the requirement is not very high of insulin. That is what we have noticed.
Anshu, please also tell us about the postpartum evaluation and follow-up. When you'd like to call her, what test you'd like to do when she comes to first?
At the end of 6 weeks, which means at the end of the puerperium, we should do the blood sugar levels of this patient again, or maybe by doing a 75-gram OGTT test. And because these patients are prone to developing diabetes later in life, type 2 diabetes later in life, and hence at 6 to 12 weeks postpartum, we should do their blood sugar levels. The best way is 75 grams of oral glucose tolerance test.
Okay. So Dr. Rashmi, last comment from your side on the contraception. What contraception advice you would like to give her? Dr. Rashmi?
I think Dr. Rashmi is
Actually,
not.
Dr.
Archana
Rashmi
can answer this.
Yes, actually, with well-controlled diabetes, I think we can use even the low-dose OC pills. Previously, it was thought they are contraindicated in diabetes, but we can use low-dose OC pills, and of course, various IUCDs, progesterone-only pills. All of these contraceptive methods can be used in a diabetic, especially if it is a well-controlled one. And of course, COCs are not to be used when she is long-standing diabetes for more than 20 years with vasculopathies. Otherwise, low-dose OC pills are not contraindicated.
So I would like to thank everyone. We are really running short of time. It's almost 7:30. And I would, your concluding remarks, Komal ma'am.
A very well packed panel, you discussed the main highlights and the main take home messages, very well covered with all the case discussions and the monitoring. But the postpartum period is a very important, because these patients of diabetes are going to have, they are going to have developed type 2 diabetes in the longer run. They are prone to other hypertension also, and all the disorders at the later age. So follow-up and counseling patient postpartum is very important, because what happens is that we deliver them and then their sugar levels, because I have one very young 32-year lady. She's working as a technician. She came to me. I had a diabetes in the previous pregnancy. She is working in a hospital, but still they are lost to follow-up, and then they don't monitor the sugar. And then I said, when was the test done? Some 6-8 months ago. I said, this is not the way the monitoring should be there. So emphasize on annual monitoring also postpartum is very, very important to keep their sugar levels in check, so that if at all they become pregnant early, like without, it can be an unexpected pregnancy, the sugar levels are controlled. It becomes really better if the patient has been under follow-up. If patient is not under follow-up and she comes with an unexpected pregnancy, it becomes really a dilemma for us, whether we need to terminate the pregnancy, whether we need to continue, and all that continues. So counseling patient and treating them and making them known that it is not only the mother, but even the infant of the diabetic mother is going to have serious implications in later life. So this is really very important. And I think all of you have done a fantastic job covering the whole topic of diabetes so beautifully. Thank you so much.
Thank you.
Thank you, Komal ma'am, for this opportunity and wish you all the best. Thank you.
Thank you. Thank you.
Thank you, Manoj
so
sir, and
much.
thank you, Komal ma'am. It was a wonderful panel.
Thank you,
Thank you
ma'am.
for the
Thank you.
opportunity.
Thank you very much.
To all the
madam.
panelists, they
Thank you, all the
have done a great
panelists.
job.
Thank you,
Thank you
Manoj
so
sir and
much,
Komal
and
ma'am.
thank you
Both
for
of
all
you.
your wishes and blessings for me in the
Yeah, all the
election. They mean a
best.
lot to me. Thank you. Thank you so much.
You're going to do very well, Komal. We know it.
Thank you, Manoj. You are a very excellent moderator.
Thank you.
We really enjoyed.
Thank you, ma'am. Thank you.
I have the two lovely coordinators, Dr. Priya and Dr. Shehla. Shehla has joined back, and I'm so happy they have coordinated it so beautifully and so flawlessly today. And thank you to both of you. You both are doing fantastic job, and I wish you all the best every time. And Dr. Manoj, the panel discussion was very great. The panelists were all very they have shared the gripping knowledge and how they have highlighted the points very beautifully and emphasizes the practical point that is very important. And thank you, Dr. Sarveshwari, Madam, for staying till the end for the panel. And thanks to all our chief guests and guest of honor, Dr. Alpesh Gandhi, Dr. Aswath, and our speakers. I think Dr. P K Shekharan spoke so well. Thank you so much. Along with Dr. Girija Wagh, Dr. Pratibha Singh, Dr. Jyotsana Daule, Sarveshwari Madam is here, and the entire team. I thank you all, and this is the end of the episode G. Looking forward for episode H sooner. Thank you so much.
Thank you.
Thank you.